that it means we're able to cover our stories, we're able to put health in a way that we see ourselves as being at the receiving end at one point or another. Some of you call us sometimes, we have this issue in SHA, what is happening? And then when I look at our reporting, then I see a disconnect. So CEO Dr. Mercy Mwangangi is here if you have any questions. And most importantly, of course, is our CS, Honorable Aden Duale, who's made it for this conversation this morning. Allow me to welcome Dr. Oluga, who will take over the program from here as we have this open dialogue before we get to the second part where we discuss the Kenya Health Summit. Tukaribisha Dr. Oluga.
Thank you. Thank you so much, Dr. Mercy Korir, and thank you, Waziri, for being here. Sir, we have a very important constituency today. We have our colleagues from the media, we have our partners that we work with, we have our county governments, and then we have your staff, all of us here. And so that we get into the substance of this town hall. So this town hall is really an open dialogue as a prelude to the Kenya Health Summit, which is happening next week, a time like this. And so we want to have this town hall with the media, with partners, with all of you. And Waziri, I like to take this chance just to have two remarks, one from Council of Governors, and then from Madam Mary, and then I'll call you to now open up the dialogue so that then you can direct all the questions to us after your opening remarks. So without much ado, I'd just like to invite Madam Mary just to say a word, and then we proceed.
It's whispering to me that protocols has been observed. The CS, and allow that I stand on already established protocol. My name is Mwiti Mary. I'm the CEO of the council. And let me say how pleased we are to be part of this dialogue that is coming to unlock a very critical conversation in this country. What remains after the reforms have been pronounced? And the question, and the million-dollar question, is not whether we tick the box in terms of delivering the reforms, but if the reforms have actually gone into improving the service delivery to the citizens that we are called to serve. And I tend to believe today is a candid conversation of where we've been, of where we are, and what is it that we intend to achieve as we move forward. And this candid conversation will culminate into a summit that will bring all stakeholders in the health sector so that we can speak to ourselves and we can speak to the country, asking these candid questions. As a primary health care been delivered under the current reforms, have the maternal and newborn health been delivered under this? As a financing component for health been delivered? And what about the HRH that is a critical component? And I think the summit accords us an opportunity to have actually these questions delivered, and delivered in a candid way where the Council of Governors and 47 counties will be in the forefront in ensuring that as implementers of these reforms, they will be telling us, has it really worked? If not, what is it that we should do? And because there is no reversal moving forward. And from where I sit, and from the information and the monitoring that we do in the 47 counties, I have no doubt to say that the reforms have actually gone into improving service delivery to the citizens. But more so, we need to get feedback from the duty bearers and from the people that the reforms have been serving, so that together we can be able to advance an agenda that is not leadership-centric, but rather citizen-centric. We are ready to receive all the questions, and we will be able to respond appropriately as we gear up to this summit that will give us an overview of where we are and giving us a way we can make it better, and together we can afford service delivery to the citizen that is quality and guaranteed. Thank you very much.
Thank you so much, Madam CEO, and most importantly is that she's ready to receive all the questions. You heard that, right? The media, did you hear that? That she's ready to receive all the questions. I think that is the most important thing about this town hall today. And without further ado, let me invite my colleague PS, Madam Mary, to also just say hello, and then I will invite Waziri.
Habari yenu. Saseni. How is the energy today? Si tumekula breakfast. So, Waziri, my colleague PS, the CEO, COG, members of the Fourth Estate, ladies and gentlemen in the house, good morning. I'm also very well this morning. Two things. For me, this is just a vital checkpoint for universal health coverage. And that is why we are doing the summit. That we need to come and tell our story. And indeed, share with yourselves and see for yourselves, hear for yourselves, and judge. The second thing is the media plays a very indispensable role in creation of universal health coverage and the health sector in general. So I would really ask yourselves that the questions that you ask out there, please ask them in this room. The opinion that you have out there, kindly clarify it in this room. And as we move to the Kenya Health Summit, it is a great time to see that all these questions, gaps are also answered. And at this juncture, I would love that we all stand up to welcome Waziri to give us the overview of the summit. A round of applause.
Please, let's be seated. Principal Secretary is present, the CEO of the Council of Governors, the DG, members of MOH, and our SAGA CEOs, our editors and bureau chiefs present here, health and science correspondents, members of the Fourth Estate, ladies and gentlemen of the press, good morning. This morning, I would like to speak candid. And of all the people here, I am the only one who has answered many questions to the media, whether it was satisfactory or not, more than anybody else sitting here. And I would like to speak very candid and hear your questions and make sure that by the time you walk into the Health Summit at KICC on the 18th and 19th of this month, you know this story very well enough, not just to present it, but to interrogate it and explain it to the Kenyan people in your own words. The Kenya Health Summit is the first event of its kind, and it's bringing together both the national and the county government, our development partners, health institutions, and everyday Kenyans, so that we can take stock of the promise we made. The one His Excellency President Ruto made in 2022, that health care will stop being a privilege for the few and becomes a guaranteed right of every citizen in every county. So this morning I want to walk you through the numbers behind that promise. Let me start with the reform that reaches into every Kenyan household most directly. On the 1st of October 2024, we retired the National Health Insurance Fund and we launched the Social Health Authority. And as of this morning, 32.2 million Kenyans 60.4% of our population are registered under SHA. And this is up from roughly 8 million who are covered under the defunct NHIF. We have paid out 164 billion in claims, processed nearly 7.9 million claims, funded 48,027 cancer treatments, over 469,000 surgeries, and 1.24 million safe deliveries. And because no Kenyan should be turned away at the gate of a dispensary for lack of coins in their pocket, our primary health care fund now lets any registered Kenyan walk into a level 2 to level 4 facility and walk without paying a shilling at the point of care. This transformation reaches beyond hospital walls. It is found in every village and every household. Over 107,800 community health promoters have been recruited. They are backed by 277 primary healthcare networks and who are today the Kenyans' frontline healthcare workers, carrying both preventive and primary care to their doorsteps. And through the electronic community, these are people who don't want to hear the good news. I don't know why. And that person, this is what the former late Prime Minister used to say, wacha mchanganyiko. Was that right? That's what he used to say. So please make sure this thing flows. This transformation reaches beyond hospital walks. It's found in every village and household. Over 107,800 community health promoters have been recruited and trained. They are backed by 277 primary care networks. And these are today's Kenyans' frontline, carrying both preventive and primary care to the doorstep. Through the electronic community health health information system, they have reached, as of today, 2.7 million households with care. We could not have made this far without Kenyans, and have been utterly honest where the contribution comes from. The national government allocated 138.1 billion to health this financial year, an 8.7% increase, while our county governments contributed a further 154.6 billion, bringing the total public investment in health to nearly 293 billion. We're also laying the foundation, the industrial foundation for a health sector that can stand on its own. Kenya now is home to 19 licensed pharmaceutical manufacturers, with 13 more on the way, and KEMSA sustains over 94% tracer medicine availability nationwide. We have further invested 9.688 billion in modern medical equipment across 239 health facilities in 44 counties under the National Equipment Service Program. Today you'll find the latest equipment in our county hospitals. And I usually use the example of King Fahd Hospital in Lamu Island, where today if you go there, you'll find a CT scan, you'll find a modern theater, you'll find an MRI, you'll find a pediatric wing, you'll find a private wing, you'll find the oxygen system working. The people of Lamu Island used to come all the way to Mombasa PGH. And these are found in all our sub-counties. This has reduced the referral pathways to Kenyatta, to KUTRH, and other referral hospitals, both public, private, and faith-based. We understand that health security is a national security, and so we are not waiting for the next crisis to start preparing for it. Today, 25 public health emergency operation centers stand across the country. They are positioned to respond the moment they are needed. When Mpox reached our shores in 2024, we detected it, we contained it, and recorded as 97.9% recovery rate among the confirmed cases. Just 2 weeks ago, on the 5th of August, the President himself launched the Kenyans' first National Ambulance Dispatch Center and a toll-free 922 emergency line, giving every Kenyan, regardless of where they live or even whether they are registered with the SHA, free access to the emergency dispatch within the first 24 hours of treatment covered by SHA Emergency Chronic and Critical Illness Fund, and through our field epidemiological and laboratory training program, we have now trained over 1,778 field epidemiologists standing guard against the next outbreak. Ladies and gentlemen, I have shared numbers with you this morning, but numbers alone don't tell the story. Behind every one of them is a mother who delivered her baby safely, a child who received the vaccines they needed, a grandfather who could finally afford the dialysis that once was out of reach, a healthcare worker on the front lines who for the first time in years is being paid what they deserve. That is the real measure of this reform. And the story only you can carry to every corner of this nation. As I put this to you directly, don't simply repeat these figures. I want you to question them. I want you to test them against our technical teams who are here this morning and remain at your disposal. Please go to the facilities yourself, talk to the community health promoters and the patients they serve every day. Because a reform that does not know, a reform that Kenyans don't know about it and don't yet believe hasn't truly succeeded. You're the bridge between what we do in this ministry and what Kenyans come to trust as real. Before we close this morning, we as a team will provide you with a complete briefing pack and the full data behind everything I have shared, along with the accreditation details for the Kenya Health Summit on the 18th and 19th of August. I look forward to seeing each of you here. As a ministry, we acknowledge the continued collaboration with the media and appreciate the upcoming coverage that will carry conversation forward into every household. Just to conclude, from where I see this meeting is very good. Because, you know, all these good people from MOH and the sagas and our partners, the only person you use his photo on the headlines is me. And I always ask them, or the first item on the television news. And I asked them, I asked the CEO of SHA, and at least the CEO of SHA sometimes shares with me her photo with the headline. But there are some other people sitting here who make very serious decisions that I tell the country, but they are never seen. Please, today they're here. Ask them the hard questions, starting with the Director General of Health. Dr. Amo, this is the man who is in the kitchen. He cooks, and he's very competent in answering these questions. He cooks and he gives it to me. But today we are ready to answer all questions. I tell people we should not shy away from the media. The media will help us. Sometimes when you send me questions, I delay for about 10, 20 minutes. Not because I don't want to answer, but I want to make sure that I do some consultation, get some numbers, and answer. And I think this morning is a very, very important morning because the success of the health sector will greatly depend on the people who are in this room, and also the entire leadership of our media fraternity. For me, I said yesterday, you know, when we were forming the broad-based coalition for the next election, I told colleagues, ministers and MPs, that it's good to appear at media talk shows and media houses. If at least you will help us pass our message, but at the end of the day, as a politician, as a leader, sometimes the media will help you to grow. You know, if you are not a friend to the media, you will finish 20 years in parliament, and when you walk in the streets, nobody can recognize you. But if you are with the media, whether positive or negative, the headline does not matter. At least people will know you. You know, it's not much that always must be positive. Yeah. And I always tell the people, even when I watch CNN, I watch Al Jazeera, you will not get positive stories. They're all negative. So this thing is a global thing. It's not only, don't blame the Kenyan media. You see what Trump goes through, the questions he answers. That is the same questions we should answer. So please, colleagues, today is an opportunity. Make sure you have your facts. And make sure that the facts you give today must be the same facts updated that you will give on the 18th, because the media will keep a track. They will tell you on 11th you say this. 7 days later, you have said this. So you must tell us, you must convince them why the difference. So with those many, many remarks, I think I now open and give it to Dr. Mercy now to take charge and tell us what is next. Thank you, Dr.
Thank you. Thank you very much, Waziri. Thank you for opening the floor for the media and also even the partners that are here. I can see some. We have 2 microphones on this end and 2 others on this end. So feel free to give your comments or question. If you have anyone specifically that you're directing it to, you can tell us. If not, we will direct it to Waziri and then he can delegate appropriately. Mr. Polilado has his hand up here. Who else on this side? Anyone on this side before I look to my right? There's a hand up there. Thank you very much. On this other side, so that we can take like the first 4 questions. Okay, we can start with Polly Lido, Group Editorial Director, Radio Africa.
Thank you, Daktari, and thank you, Waziri, and your team. My name is Paul Ilado, and I have just 2 questions. It's almost 2 years since we launched SHA. What are the 2 biggest challenges you've had to deal with? And then the second issue, what next after today?
Thank you, Paul. We have a question at the back.
Yeah, good morning.
Your name, media house, and if you're directing your question to anyone. So that was to Shah, Waziri.
Asante sana, Daktari. My name is Joseph Wahungo. I'm a reporter at KBC TV. I would like to ask a question directed to COG, but also the Minister of Health. We are having this meeting when we're having our clinical officers and nurses having gone on strike, and we know that health workers is a very strong. Health workers are very important because the government has trained many of them, many of nurses, many of doctors, clinical officers. But apologies. When we go to their function or their meetings, they always complain about poor working conditions, lack of payment on time. And I'm just sitting here and wondering, is this an issue that the ministry is worried about, or even the COG, that health workers who are supposed to be, serving Kenyans and especially the needy ones are not at their places of work right now? What is, of course, we know governors have said the issue around payment, or of course absorbing some of the workers, especially the UHC workers, into the permanent and pensionable is something that the government, national government, needs to look at. Is that something that the two governments have discussed, so that of course we have these industrial actions end once and for all? Thank you.
Thank you very much. That's a question on human resources. Linda.
Thank you very much, Daktari. And I'm glad that you put this meeting together. It's quite impressive that we have, faces that most times we just see on TV, like Dr. Luga here, Dr. Amoth. So finally, nice now to see you one-on-one and to put you on your defense. And Honorable Duale too. Right? So I'll make some remarks and also ask a question. I believe that health is wealth. And without health, you're poor. So through my work as an editor, I interact with stories of citizens suffering in hospitals at every level, including level 6 facilities such as KNH, where lately insecurity has become a concern. Buona CS, you've given us very impressive figures, 32.2 million registered in SHA and 293 billion invested in health. So my question is, health is a devolved function, yet national government remains deeply involved through SHA and other health financing and policy mechanism. So the question is, where is the answer for the ordinary citizen? So we changed the system acronyms from NHIF to SHA. But does the patient experience when they walk into hospital, has it also changed? That's my question. Or we just change the acronyms? And then last but not least, when patients walk into hospitals, can we confidently say that they get the treatment, medicine, and specialists when they need them without being pushed into financial hardship? In Kenya, we mostly know that you're just some disease away from poverty. The moment maybe you're diagnosed with something as serious as cancer, then now, the next step is that you're going to fundraise to get treatment. So I'm just posing a challenge to you that when healthcare fails, who is accountable? Is it the national government or county government? Because to ordinary Kenyans, they just know one government. I hope from that you've got my questions. Asante.
Thank you. Thank you very much, Linda. We'll answer those questions, and I think we can answer from there because we'll be able to show from the screen, unless you want to come to the podium. Okay, that's fine.
Yeah, thank you. I believe these things. Waziri, I believe the instructions you've given to me is just to distribute the questions. And not to answer them, unless you direct otherwise, Waziri. We are live in media, so you can direct me otherwise. So, sir, the first question was from Paul, and Paul has asked two questions, very abstract. One is the two biggest challenges since the establishment of SHA, and number two, what next after today? I think, Mercy, you have the floor.
Thank you. Thank you. Thank you, PS. I sit here. So, okay, I stand there. Okay.
right here.
Yeah, you can start.
Yeah. Last time I got on a stage, I fell. So I'm scared of stages now. Thank you so much for this opportunity to be able to share. Peter, I think I saw Peter standing somewhere there.
Paul, yeah.
Paul standing somewhere there. So Paul, what are the main, you said 2 challenges. There are more than 2 that we faced as we've been rolling out SHA. But I think for us, one of the things that we need to understand is that when you introduce a reform, when you introduce any new component, assignment, project, you have to deal with being able to ensure all stakeholders understand why you're introducing it, they understand their role in the reform, and that they're able to participate in the reform. One of the things that we've grappled with is what you call change management. I was just sharing with some media teams outside here that in NHIF, for you to review a claim in NHIF, you had to have your claim submitted at the branch level. And I actually have pictures on my phone of Nyeri branch, the former NHIF Nyeri branch, where a QA would sit on a desk and would be towered by files all around the QA. And the QA would then determine which claims he will check. So if you are a health facility, you would talk to the QA and you would ask them, please look at my bundle of files. Right now at SHA, and I was sharing with the team, all our claims are digital. There is no single manual document that any claims officer has to look at. And that's an improvement digitally because everything is done digitally. But it means that we have to go through change management, teaching our providers, teaching ourselves, how do you then move from a process that was highly manual into a highly, completely 100% digital process. So change management in many, many facets. For Kenyans, I've heard many Kenyans tell us we've not done enough in communicating our benefit package. Even this morning, I was sitting with the PS, and she's telling me about her brother-in-law who is looking for radiology services in Karen, right? So there's more that SHA needs to do in educating Kenyans what the benefits are. What are the benefits in primary health care? I'd be asking you, Paul. You're an editor or you're in the media fraternity. What do you get from LN 56 when you go to a primary health care facility? What do you get from Kenyatta or even a level 5 like Mbagathi, which, by the way, this reform has subscribed in law? Another key difference. In NHIF, the benefits were arbitrary. The CEO for NHIF could decide if they'll pay your bill or not. Right now, as a CEO of SHA, I cannot. I'm mandated by law what to pay, when to pay, and how much. So change management in really educating us all on how this new reform, is implemented and the roles that we all have to play. The second component that is an issue is something that we've spoken a lot about. The minister has supported us heavily when it comes to issues of fraud. Global indicators of fraud tell us all across the world, America, UK, Scandinavia, health insurance fraud is a menace. My auditor, Parken, and I think he's in the room here somewhere, he's come to support us. I was telling him, you need to go and look at the FBI special unit for medical fraud that America has formed. That's how fraud is in health insurance industry. That America, the #1 nation, has formed a special FBI fraud unit just for claims, not for anything else. That, of course, is something that we struggle with, but again, our digitization has come in to support those efforts. Every day, we learn new behaviors of all the actors of fraud, who include 3 parties at SHA itself, officers at SHA, officers, providers, health facilities, and you Kenyans in this room are all participants of fraud. I was sharing with the minister last week. We had one of the premier facilities, private facility that is probably the #1 facility in this country, come in to tell me that a lady who is a civil servant had brought her sister using her benefits and had admitted her sister, a civil servant, in the premier institution in this country. And the sister had to run when the medication was being given because they were switching at night, the hospital gowns, and they were busted. That's fraud by Kenyans. So in the media, we are very good at saying 11 billion lost at SHA, and then having the minister's picture in mind there, but it should be the whole country, all of us. We should put our picture on that newspaper headline, because we are all complicit. I think I stopped here.
Thank you, Sha. So 2 biggest challenges: change management, fraud. I think you got that clearly. And I'll talk about change management also at the hospital level, where systems at hospitals were not aligned with patient claim journey. And now, SHA, because of the law and because of digitization, hospitals have also had to adapt. And that is why you see some hospitals doing very well, and others are always complaining, because if they had not established proper systems, then they cannot cope up with what Mercy has just mentioned. Waziri, there's the next question about what's next. I think what's next, Paul, is that today we are here, Waziri is here, everyone is here. We start a new journey of stating the facts of the reforms and what has been delivered. And I believe that we are going to clarify all of this in this town hall. Waziri,
what I meant by what next is in the journey of transformation. In this journey of transformation, what are the next steps going forward?
All right, I think that is going to come very clearly. Waziri has the answer.
It's a very good question Paul has asked. What is next? And we will answer that at the summit. Because at the summit, what are we doing? We are going to showcase what we have done already in the last 4 years. Yeah, we are going to showcase what we have done in the last 4 years in health financing, in equipment, in registration, in how do we deal with the maternal and newborn mortality rate, what are our numbers in cancer, what is our plan. Then we also look at what are the challenges that we have faced in making sure this reform, health reform, is delivered. And together as a country and partners and everybody, we will see we have reached here, and this is where we are going. So the whole roadmap of what next is in fact the question, the elephant in the room that we will answer between 18th and 19th. First, we showcase what we have done. We show you the challenges. We see the opportunities. And today we are at 60.4, I think. We are very close to universal health coverage, and we'll be the first country in Africa that has achieved that. Many are coming to learn. So I think it's a very good question. What is next is now the discussion that we want everybody, what citizens are supposed to do, what the media is supposed to do, what government, both levels, are supposed to do, what our partners are supposed to do, so that we complete the circle.
Thank you, sir, for answering. And sir, with your permission, the next question was about health workforce. So if you allow me to invite the two Marys to jointly and tackle the issue around the health workforce. I think we can start with, I thought that we can start with Mary, just to lay the foundation of the role of the national government, and then at the service delivery level, invite the COG CEO to answer the specific questions about.
Thank you very much. Thank you very much. We truly realize that healthcare workforce is one of the key agenda items in the health sector. And without healthcare workforce, we cannot function. All these things that we are planning is going to water. And that is why you have seen even the number of strikes that used to be there have really subsided. I know there is a bit of an ease at the counties, which I will invite Mary to come on board and explain further. However, we are not where we used to be. From the transition to PNP of the universal health coverage, to the payment of the doctors, to the arrears that used to be there, signing of new CBAs for the nurses, the clinical officers, and career progression for many of the unions and also cadres in the country. Therefore, we are not relenting and we are not slowing down. Every issue around the healthcare workers and healthcare professionals is going to be resolved bit by bit, whether it is at the county level or the national level, because we do not have a patient for counties and a patient for the national level. And that is why, in collaboration with the second Mary, she will come and elaborate further why we have a bit of a need in some counties, because not everywhere, it is in some counties. And this is very specific. It could be an issue of PNP, it could be an issue of promotion, it could be an issue of progression, career progression. And Mary, please.
Okay, thank you very much, PS. And the question was, why the summit and in connection to the labor unrest that you are seeing today? And I want to say that this summit would not have come at a better place than now. There are a section, and I say a section of healthcare workers are on strike. Just to give a chronology, 14 years into doing devolution, we stand at a better place than we were previously. Health labor unrest has drastically reduced compared to the last 7 years, meaning that we are growing by the day, structures are formed, systems have come to foundation, and for that reason there's some levels of convergence in terms of the service provision and the interests of the unions. We are here, and I want to confirm that we have only 2 cadres that are on strike. That is the nurses and the Kenya Union of Clinical Officers, but it's not in all the counties. It's a section and a few counties that are varied, agreements here and there. Allow that I start with KUKO. For KUKO, CBAs have already been signed off. Return to work formula has been executed, but there is a process that ensues in terms of the implementation thereof. After the CBAs have been signed off and return to work formula has been signed, there has to be a concurrence by the SRC to agree on the remuneration and the allowances thereof that has been given off for purposes of standardization and ensuring that there is harmony in the entire civil service. If it's a job group M, then whatever that is prescribed for level M then caters for each and every cadre in the workforce, in the civil service. That is yet to be finalized. We did a letter to SRC to confirm the same, and I think KUKO should have actually waited because we already agreed, and most of the counties have started implementing that as we wait for the SRC to give the concurrence for purposes of registering the CBAs in court. That is what gives authority for purposes of execution of the allowances. I tend to believe, as it is right now, there are just a few counties in terms of clinical officers that are on strike, not all of them. For nurses, yes, we agree there's a strike, but it's not across all the counties. And for that reason, we had an engagement with the governors on a Thursday where we agreed on draft of measures so that we can forestall the continuity of the strike. We are yet to receive a memorandum. We were to receive it by latest tomorrow. So we are waiting to have the memorandum, and the Council of Governors and the 47 counties are ready to engage and negotiate with the nurses for purposes of ensuring that there is full restoration of service delivery to the county, to the citizens of this country. So in the summit, I tend to believe one of the critical components that will be discussed is human resource for health. What is it, so that we can get feedback from you on how to better this relationship. But I want to confirm there is a lot of improved relationship between the unions and the counties as we move forward. So there are just a few counties that are on strike, and I tend to believe by the end of the week we'll have agreed, because the issues are not as much as the populace is actually being sought through. There are just a few issues. So we are addressing it, and I tend to believe by the time that we go for the summit, then all the labor unrest issues will be solved. Thank you.
Thank you so much, PS Mary.
Sorry,
and
on UHC,
please
I tend to
proceed.
believe that the CS will be able to give just a brief on where we are. The issues of UHC have been agreed upon between the 2 levels of government, and I think the CS will be giving the status update because we are at a good space. Thank you.
Before Madam CEO, you said on UHC, and I know, let me move here, Waziri will come. We did what we call mystery shopping, go to facilities. So we went to primary care facilities just to assess, because by law, primary care is free. And we were charged 20 shillings to buy a book. You know that ile kitabu na karatasi book, exercise book, unakata katikati na kwa nusu. So we were charged that as part of the registration in one of the facilities. In another one, somebody went for emergency care and they were charged 520 shillings kufungua file. And I know Dr. Mercy has come and said, you know, it's free and everything is digital. But somebody was charged 520 kufungua file. These are barriers to accessing healthcare. Counties are at the heart of service delivery. So with the remarkable number, 60% registered, but at the point of access, 20 shillings is a lot of money for a mother who walked to the facility only to be charged when they are not supposed to be charged. I don't know. The experiences, and it ties to what Linda said, the experiences for Mwananchi on ground is very different from what is prescribed by law, and it sits at the heart of the counties. If you'd like to comment on that. Thank you.
Thank you very much, Mercy. Allow that I say, for each and every system, a new introduction of a system, there are challenges along the way. And I want to confirm 2 years after the rollout of the health reforms, I can actually, from where I sit, that it has worked extremely very well. There are challenges that there are, like those ones that you're giving out, but challenges that are actually isolated. And when you're rolling out a system, these are some of the things that you keep on, on a daily basis, asking how do you then better service provision on a daily basis. The Ministry of Health gave us an advisory that primary health is actually free at all levels. The Council of Governors did disseminate these to all the counties. And we keep on checking track on whether this is fully implemented. And I have said again, there is no system that doesn't have some few challenges, teething problems here and there. And that's why we are welcoming some of these feedback, so that now we rein on those counties that are actually charging that very little fee because it is too much for a citizen. But from where I sit, it is actually a continuous improvement process. So those counties, and Mercy, because you're a friend, we are walking this journey together. We have to make this system work for all of us by receiving feedback from you. So we'll be able to act on that, because primary health service provision across all the health facilities is free. But those isolated cases will be handled as we move forward. But advisory is already there. Thank you.
Let me answer UHC. Because UHC is... I think let me start with what Mercy has raised. Primary health care, level 2, level 3, and part of level 4 is free. A Kenyan can walk in and walk out is treated. Any facility, be it faith-based, be it county, be it private, if they charge, even for that exercise book, it is a criminal offense, it's against the law. It's against the Primary Health Care Act. Together with that, and what is the genesis and the philosophy behind that? There is the Facility Improvement Fund. Today, facilities in very remote parts of our country, dispensary health facilities, have testimonials that they have received between 500,000 to 2 million that they never used to get during NHIF. So I agree with Mercy, and I agree with the CEO, Council of Governors. It's part of the challenges. There are some facilities that want to charge. But let me say it, even in this financial year, government has put a budget of 19 billion to treat Kenyans who go to dispensaries, to health facilities, to some parts of level 4. You charge a Kenyan, it's a criminal offense, regardless of that facility. I think that should be very, very clear. 2, I think UHC, the history of UHC is they were employed during the COVID, 7,000 plus. When I came to office, the first group that introduced me to MOH was at the gate were UHC demonstrating healthcare workers. And when I asked my PS Mary then, Oluga was not there. They told me, don't worry, you will go through you'll go home through the exit of the Ministry of Health. Ministry of Agriculture. And I told them, I'm not the Minister for Agriculture. This is my gate. So I will talk to these people. So I went and talked to them. And we have covered ground working with the Council of Governors. Today, as we speak, UHC staff have a pay slip written permanent and pensionable. Today, as we sit, UHC staff are being paid the amount for permanent and pensionable. In fact, we have started deducting SHA, the housing levy. We are putting money aside for their pension. So they are permanent and pensionable. What is remaining is just the counties to regularize removing them from a contract to permanent. And that is because we found a challenge. When the Senate was doing this financial year relevant bills, the Division of Revenue Bill, the DORA, that amount was supposed to be put as an equitable share. But the amount for UHC was put as a conditional grant. And that is why right now, working with the Council of Governors, in fact, tomorrow, there's a meeting between the chair of the Council of Governors and Health Committee and the CRA. And once that is completed, we go to Senate. I have written to the Senate, I have written to the National Assembly, that they do that legal rearrangement. Remove the money from the conditional grant and put it as an equitable share as under DORA. But yes, but as we do that, PS Oluga is already paying them as permanent and pensionable. So I really want to urge our UHC staff. You are 7,000 plus Kenyans. We care about you, and we have worked together this journey with the MOH and our county government, Council of Governors, and I think we should complete it in the next few days. Thank you.
Thank you, Waziri. Thank you so much for that leadership. Waziri, I have to confess, you made my work very easy. You know, I previously was on this health workforce thing. And sometimes I don't want to answer those questions because I may be accused of conflict of interest. But when it comes from you, it covers the conflicts that may be perceived. Waziri, there's the question from Linda about the everyday experiences of patients. And I just wanted to state that the reforms which have been outlined by the CS in his speech and with the numbers, and I'll make it perhaps understandable from a layperson perspective, where a lay could even be our health workers, are only meant to achieve two things. One is that we must protect all Kenyans or all citizens from financial ruin. You know, Kenyans going into poverty, and you mentioned that, Kenyans going into poverty because of healthcare. That's the entire story about SHA, to make sure that every Kenyan does not sell their asset or does not sell their business because of healthcare, and or does not delay to get care because they are worrying about where care will come from, including the National Ambulance Dispatch Center, so that you don't have to worry. We had, I'm sure the media was here. In 2015, October, the Nation Media Group had a big headline about Alex Madaga. You know, you say you are a house of record, so I'm sure the media knows that. So when the president launched the emergency chronic and critical illness fund and then matched it with the launch of the ambulances, which the CS has talked about, and the 922, it meant to solve those kind of problems. People not going into financial hardship. Parliament has discussed, there was a case again that appeared in the media, this lady who was charged 800,000 at MP Shah because of emergency. These are the real problems we want to solve, and it's meant to sort out the suffering that you're talking about. But the second issue is to ensure that people don't die from causes that are preventable. Things that we can prevent. You know, like we say, pregnancy is not a disease. So why do mothers die? So that's the entire investment around maternal and newborn health. Issues that like cancer. Why do people die from cancer? Things that you don't have to die from. That's the entire investment around National Equipment Service Program with the mammograms. Because if you detect that cancer early, you can treat it early. And so, your question about change of acronym and whether the experiences have changed is the reason why we are here in this town hall. So that from our stories, you can go to those hospitals and ask the patients, and not just the ones that we have handpicked, across the board, what's the feeling? Have those experiences changed? We know that healthcare is extremely personal. And out of 100 patients who come to the hospital, maybe 4 of them will say, I wasn't treated very well, something did not go very right. But there is the other 96 or the other 95. Perhaps we could also broaden our coverage so that then we get this answer correct. And I believe this is the reason why we want to have the Health Summit, so that we document the achievements and then we talk about the next plans, as has been mentioned. I think Waziri has made this very clear, so I'll take it back to Mercy again so that we get to the next round, and then Waziri will guide us whether it...
Okay, I have, there are some 2 questions this side. Okay, if not, there are burning ones on this side. Misheni, just next to you, there are ladies. I'm biased to the ladies, and then we'll come to the gentleman here.
Good morning. My name is Gloria Milimo from KTN. My question goes to Dr. Mwangangi. I would just want to know whether the SHIF fund is in debt. Has it committed to pay claims that it cannot finance? Considering the number of registrations, we have 32 million people who have registered, but how many of these are paying? Looking at data, the data I have for the past 15 months, sorry, that's the period between 2024 and 2025, only 90 billion shillings came from the formal sector. Majority of these members are from the informal sector. What is SHA doing to ensure that it bridges this deficit that we are seeing in terms of revenue collections? Thank you.
I'm Mercy Kahenda, health and science journalist from The Standard. Just to add on what my colleague Gloria has said, my question would be on the contribution, because from this, as per the contributions remittance analysis report from SHA, we are only having about 5 million Kenyans paying their premiums. So when, as much as we pride on the 32.2 million as registered SHA membership, how much are we receiving from these individuals who've registered with SHA, and is it we are doing to onboard those people in the informal sector who are less than 1 million. What is it we are doing about this? Then my other question goes to Waziri Duale. He has spoken about KEMSA having improved its refill, but currently we are experiencing shortage of essential drugs, including contraceptives. So what's causing this? Why are we having shortage or why are we running out of stock when KEMSA is able to provide what's required with by patients across the country? Then my last question goes to the COG. Currently we are having lots of issues to do with counties. Has counties really taken up the devolved health as a devolved unit? We are having lots of, as much as we are talking even the refund from SHA to the primary health facilities, are we having counties improving services within these facilities, like ensuring we have health workers employed? Are we even having equipment? Someone walks to a dispensary but is not even equipped to provide the required services. That's why people get to be referred to higher facilities. Thank you.
Thank you, Mercy. And as we get the next round of questions, I like maths and numbers. So her question on 5 million contributing and there's a gap of 32 million usually is one of the questions I like answering. So Dr. Mwangangi, allow me to answer this on your behalf, and I declare no conflict. Yeah. So for me, if you think about it, how many of us here are parents, have spouses? Hi, am I the only parent here? Okay. If you have your children and you're a primary contributor to SHA, are your children going to pay to SHA? So it means you have 5 million principal members and the rest are dependents who are not expected to pay. So whether SHA is in debt or not, Mercy will answer, but that should give you the deficit. And I know the mathematics usually is for every principal member, you have approximately 4 dependents. And remember, with the reforms, you can add as many wives as you want, as many children as you want, as long as there's proof. So it means, or even as many husbands, as you want. So that should tell you, that should answer that gap. I'm sure with the increase to 32 million, then the principal members paying up should have increased. And so Mercy will come and clarify those numbers, but I think I've helped you a bit because, I look at numbers and I like working with numbers. Sorry, let me take the other questions.
My name is Theo Masharia, representing Hope Media. Maybe 2 or 3 questions. Number one, there has been a push and pull between the government and hospitals over a proposal to deduct 2% on every SHA claim to fund the digital superhighway. There was a time we were with the CS and we asked him that question, and he told us the amount has been capped to around 5,000. But again, we'd wonder, what about hospitals that handle complex procedures where this amount exceeds the capped amount of 5,000 shillings? Maybe we would hear. And also number 2, what informed this proposal to deduct 2% on hospitals for the purposes of funding the digital superhighway? We've had claims that this money, one way or the other, is not really funding or doing what it was supposed to do. And number 2, also we'd want to understand this morning, some 2 or 3 months ago, Waziri told us that the SHA settlement claims stands at 74%. We'd want to understand, as we sit here today, how far are we when it comes to settling the SHA claims? Maybe how much currently does the ministry owe hospitals, and also how many claims are pending so far? And maybe I know I won't get another chance to ask this one, the last one. Are we still on high alert when it comes to Ebola preparedness or Ebola alertness? Thank you.
Good morning, everyone. My name is Anne Mawathe. I'm the editor-in-chief at De Frontera. I'm going to ask a pretty different question from everyone else. It's about malaria, and this is for the man in the kitchen, Dr. Amoth. How are we preparing to control or manage the new parasites, and specifically PVVAX? I've just come from Wajir, which is one of the 5 counties that have reported cases of PVVAX. The main drug that treats PVVAX, Primaquine, is not stocked by KEMSA, which means the people who are suffering from PVVAX, now in Wajir, they had bought their own supplies, but they've run out. It's been 6 months now. What is your response to this? Are there plans to stock this particular drug? And going forward, how are we preparing as a country to confront these new parasites in malaria control?
Thank you, Anne. We'll answer those questions and then we'll come to a final round of questions from this side because I can see many hands here. So let's answer those ones first.
Okay.
Madam PS.
Thank you. Thank you very much for those questions. The first one goes to Mercy on SHIF, ECCIF, and PHC fund.
I'm really enjoying these questions because where is Kahenda, my favorite person? Mercy Kahenda, where is she? There we go. I was trying to think, how do I explain how we structured this reform? Why do we have all the funds that we have? And the best example that could get me closest to this was what was done in the times of Kibaki in education. When we did free primary education, then looked at secondary and university. If you use that analogy, I want you to think of SHA as a graduation scale of funds, whereby we've set up 3 funds that help us mitigate against diseases in the country in a graduation fashion. Now, statistic number 1, 70% of health needs in this country are made and met at the primary healthcare level. That's a fact. Let me repeat. Many of the conditions we suffer from, the flus, the colds, the diarrheas, the nimedungwa na mwiba nikiwa kwa shamba, nasikia hivi maumivu, all of those things, our data shows us that those conditions are handled at the PHC level. If you open, and I think I've seen WHO in the room, I saw one of the WHO rep, some partner here. Yes, there we go. She will tell you that an investment in primary healthcare, a shilling in PHC, helps you recoup 9 shillings out, the ROI of PHC. What we haven't done a good job of, and as a health economist, and I talk as a health economist, forget about COSHA, is that this government has put in place 27 billion Kenya shillings under PHC in 18 months compared to the previous government that put in 1.8 billion. So for someone to come and stand and say we've merely registered 32 million Kenyans, it tells me you don't understand this reform. And I'm being blatant here. You do not understand this reform, but that's why we are here today. And that's why we are here today. WHO will stand and tell you a country that invests in PHC is investing in 70% of the disease burden. And that's monumental. Even for me as a CEO SHA, if we just focused on PHC, I would be happy because that's tremendous. And I want the media to understand this. And I'll say this here today and 10 years from now. The PHC investment is gold for Kenya because it means 32 million of us, should we have an issue that can be addressed at the PHC level, can walk in and walk out, abate all the challenges we've had. Kitabu, I've been there, I've done mystery shopping in Kilifi. I paid for a book and I sent the message to Governor Mungaro because I paid 20 bob in Malindi at night. And I told him he needs to look at his system and stop that. But Kenya has made tremendous gains in investing 27 billion for PHC. Now, what is UHC? UHC is about having all of us in a common basket covered. And I've just described that our structure has a graduated 3-tier structure: PHC, SHIF, ECCIF. The nirvana and goal of this country, and for you as a Kenyan, you should be self-interested. It's not just about publishing headlines. You should be self-interested that all of us will be covered in all those funds eventually. But but it's a journey. And that journey is determined by your fiscal space, your envelope, the resources that are available to be deployed to those funds. PHC, government has put in 27 billion. Government is telling you, should you have a PHC need, go in, access it. If there's an issue, alert us. When it comes to SHIF is your mama chama. And I want to be very clear on this. SHIF is a contributory fund. You contribute to access the benefit. I repeat, SHIF is designed as a contributory fund. So you contribute to it to access the benefit. Much like the same way when you save in a chama, then you get the resources of the chama. If you don't save, there's no money for you. SHIF will succeed and will continue to succeed in this country if all of us contribute to it. And I love what Mercy has shared. When that question was asked, I was pulling out KNBS data for the media. And I'd want you guys to really support this country in being bold in your reporting, but in researching your reporting and not being lazy in your reporting. KNBS tells us, yes, KNBS tells us the labor force participation in Kenya is how much? Let me ask. What is the labor force participation in Kenya? How many people in Kenya participate in labor? Because that's the number you use to measure the 5 million you're talking about contributions. How many? And she's right, it's about 11 million of us. So every time you're gauging on who is contributing into SHIF, then you're looking at the formal and informal sector, and you're trying to ask SHA, are there 11 million people in? Today, the number that we have is about 3.8 plus 1.2, so it's about 5 million people. But I repeat, it is a contributory fund. If you're not contributing, you're not in. And that's the design of this fund. If you're not able to contribute, because of whatever circumstances that life has dealt you, then there is a sponsorship program that government has put in place, 3.6 billion every year, to take care of indigents and vulnerable groups who are not able to contribute into it, but it is a contributory fund. So when I was sitting here, I was showing Waziri, and I'm glad Anthony is here, because he's the one who's made this possible. Right now, Mercy, we have close to almost 10 million children. Do you want these kids to pay for SHIF? That's why I'm saying research. Ask intelligent questions, research. No, I'm being serious. Let me say it. I'm going to come to the 32. It's right here. Yes.
Now, let us have one meeting, one question at a time. So I need that lady to be given the mic.
Let her come in. Continue.
Kindly.
The 32 million.
One meeting.
I said the 32 million are registered people. These are registered and contributing. It also consists of registered but not contributing and their dependents.
Yes.
So when we say there is a deficit in terms of contribution, that's what we need to understand. What is SHA doing to bridge this contribution gap for sustainability purposes? Thank you.
Good. So 32 million Kenyans are registered, right? No, that's an intelligent question. And guys, I want you to, I want, as I give this to the minister, I want to preface. I'm saying let's use data. That's what I'm trying to land us at. Yeah?
I agree with you. Martin should have said, let's ask factual questions, not intelligent. So I have apologized.
Thank you, Waziri, for apologizing. Waziri, you know, SHA is very emotive. So even sitting there, I also get very emotional because I have my numbers, but I agree. Let us focus on the numbers and the facts. Now, it is okay, guys. I will share all this data with you, Mercy. Now, okay, I also apologize for saying it's not intelligent. Very good. Now, we look at the numbers, right? We've agreed. We look at the numbers. So we have 32 million Kenyans that are registered. These are principal members and their dependents. The ones who've paid, the Kenyans who have a pay slip. So we get them through KRA and the statutory mechanisms are about 3.5 million Kenyans. And this figure shifts depending on the employment status of the Kenyan. Then we have, no, that should not be the headline. Then we have informal sector Kenyans. These are Kenyans who are not captured in the payslip mechanism. We usually have about 1.2 who have contributed into SHA. Every month, depending, and this fluctuates, from the formal sector, we get about 8 billion in contributions. These are the payslip people. From the informal sector, we get between 500 to 700 million. Again, it fluctuates. I want to insist, this fund is contributory. So the people who will get the benefit from that fund are the people who've registered for that fund and paid for that fund. Now, what should we be doing? Someone asked what's going to happen going forward. What does the future look like? What are we going to be discussing next week? The idea is countries who've gone before us have ensured that their people pay into the SHIF fund. And how have they done this? One, proxy means testing. We've designed a mechanism that enables Kenyans who are in the informal sector to be able to contribute their premiums after we've done their proxy means testing. And it's not popular. Kenyans do not like proxy means testing. But I can tell you, the world over, countries who put in place these systems need a mechanism to be able to define how you net in the informal sector. And for us, Kenya, we've started with the proxy means testing tool. When you do proxy means testing, because your income is not predictable month on month, that tool enables us to determine what your monthly contribution would be and you're paying into the SHIF fund. Going forward, we're exploring many mechanisms to bring in more Kenyans, particularly in the formal sector. And the first one is called agency model. We will set out agents who will be able to sell insurance the same way you see Britam and everyone else selling the insurance on the streets, knocking and saying, do you have a Jubilee cover? Do you have a Britam cover? Do you have this cover? We will have SHA agents going around and selling covers to the informal sector on commission for them to pay in to the fund. But at the end of the day, remember, SHIF is contributory. Now, someone asked, how many claims have we paid? And how many claims have we had submitted? When I get into the system so far, for SHIF, in terms of our collections for SHIF, let me just open this so that I read directly from the system. If you look at the primary healthcare fund, to date, Treasury has given us 27 billion. You got that? 27 billion. SHA, through PHC, has paid out 23 billion to providers. That's PHC. When you look at SHIF, this is the contributory fund, we've collected 151 billion. And this is over the last, since the inception of the fund. And we've paid out 134.7 billion. You've gotten those figures? We've collected 151 and paid out 134.7 billion. Then ECCIF, this is the new fund that we just launched. We've collected 8 billion and paid out 3.5 billion. Then we have the Public Officers Medical Scheme Fund, where we've had collections of 17.2 billion and payouts of 16.9 billion. So cumulatively, SHA, over the last 19 to 20 months, we've collected 203.7 billion and paid out to providers 178.4 billion. Right now, as we stand here, this is our week of payment. So these figures will change. In fact, before the summit, these figures will be updated. And by the time we get there, under manual review, what we call the claims under review, the ones that SHA is holding right now for providers, they come to around 29 billion. Those are the claims that we have. But those claims are not claims for yesterday. Those claims are aged, what you call an aging analysis. So we have, for example, I was looking at the data during the NADEC meeting, and Governor Abdul Swamad was asking me how much do we owe county governments. Today we owe county governments 4 billion. 4 billion Kenya shillings. That 29, when you break it down, it has county, it has private, it has FBO. We owe county providers, all of them, as a group, 4 billion. And that 4 billion can be aged. What we owe you within 90 days, what we owe you within 60 days, within 30 days. Our contracts say we must settle you within 90 days. And so some of that money, and someone asked a really good question on, is SHA sustainable? I had someone ask a question on that. That's the answer there. That we actually have resources to pay out these funds, and that we have a 90-day aging contract for that same purpose. And when you go to our partner industry players, for example, if we have providers, I saw Chris here. Yes, Chris is here. If you ask the providers, how often does Jubilee pay you? How often does Britain pay you? When does UAP pay you? Then you'll come and see that SHA actually has some of the fairest settlement times within the health insurance industry in Kenya. We're actually doing better than private medical insurance. So for me, when I hear SHA sustainability collapse, this is what the numbers tell me. And we are not there. Rejected. Right now, rejected. Anthony can open, but I saw 17 billion. If I'm not wrong, Golda, I saw Golda somewhere there. It's 17B? There we go. Rejected 17 billion today. Returns 13 billion is our returned claims. Now, maybe Waziri will define what returned means. A returned claim is a claim that a provider has sent to us, and for some reason, there's a missing component in that returned claim. And that if they action it, for example, it could be restate the discharge summary, it could be clarify on the treatment given, it could be relook at these dates. That provider actually has an opportunity to go work on that claim and return it within 14 days, and that claim can then become an approved claim. So when you hear a provider saying SHA owes us, usually we'll call the provider and ask them, let's see what your rejects are. Let's see what your returns are. Let's see what your paid is. And more often than not, the provider will say, okay, fine, I see I have returns and I need to action on the returns. I hope I've covered that.
Thank you. Thank you. Thank you so much. A round of applause for Mercy.
This one, because I think it's good, we have an opportunity to say many things this morning. Mercy said, for example, the counties, SHA owes them 4 billion. Tomorrow, counties might say, no, SHA owes us 10 billion, or 5 billion, or 6 billion, or 7 billion. The difference is they are counting the rejected, they are counting the return. Okay? Same with the private providers. Same with faith-based. Same with our referral hospitals. KNH debt with Mercy might be 1 billion, or all the referrals might be 5 billion. But after you remove the rejected, you remove the return claims. And the return claims even has a statutory timelines within law. It says, for example, you said you have a claim on delivery, and then you forgot to attach the birth notification. That claim will not be paid by SHA. It will be returned. If your facility claims deliveries where 95% of the deliveries are C-section, SHA will not pay. That is fraud. Because how come every mother who comes to your facility is going through C-section? Just because there's more money for C-section than normal delivery. If that goes on and that data gets out, we will have a problem with the WHO. There is a ratio for a facility when it comes to normal delivery. So if you add the numbers, I have the numbers here, which I wanted to give earlier, but Mercy has said it. You see, and thank you, Dr. Mercy. I think people are asking, this 32.2 million and the people who are contributing. First, we are not saying how many Kenyans are accessing free primary health care by only just registering. They don't need to pay. How many Kenyans are accessing the emergency, chronic, and critical fund without paying? An ambulance will pick you. It will take you to a hospital. The first 24 hours, whether you are registered with SHA or not, Mercy has to pay. But if you look at the receipts, there is total receipts. PHC 27.4, SHIF 151 billion, ECCF 8 billion. For the Public Officers Medical Fund, these are the teacher, the civil servants, and the police, 17.2 billion. Total 203 billion. How much have we paid? PHC we have paid 23.2. SHIF we have paid 135. I think ECCF 3.8. For PMSF, I think 16.9. 178 billion. Then, and these are facilities, for PHC, 9,341 facilities across all the service providers, public, our counties, the faith-based, the private, and 9,300 PHCs that Kenyans can walk into, walk in, walk out, paid for by government. Then SHIF, we have about 6,000 facilities where premium holders can go and access in all faith-based, private, and public, and including the level 5. And then CCF, 719 facilities. So I think that is the reason the question of 32.2 we have answered. There was a question on KEMSA. The CEO of KEMSA is here. He will answer his question. The question on Ebola and malaria, there is a man called DG here. He is a technical advisor to me and to the whole government, including the president. So malaria na Ebola, ujipange. Ile swali lingine lilikuwa ni gani?
There is one question for
Yes, DHA. Come and explain this 2%. Today I'm not going to answer. First, come and tell people what is DHA, what is this superhighway, what is this 104 billion some people are asking. And please don't be like Honorable Kalonzo yesterday when he was about SHA. So make sure you answer those questions.
Thank you very much. A round of applause for Waziri. Just before I call upon the DHA CEO, I want to say that a healthcare system is not a single entity. It's a complex, interdependent ecosystem that is governed by a social contract. And when it collapses, the failure is rarely isolated. Building a case for universal accountability requires recognized that every stakeholder, including all of us who are here, from the highest levels of government down to each and every individual, we hold a crucial piece of puzzle to put together. So whether it is from government and policymakers, whether it is from healthcare administrators, whether it is from medical professionals, we all have a part to play. And that is why we are here today. DHA.
No, this is man. DHA comes last.
Okay, DG first.
Thank you, Waziri, for
talk about
the
whether we are prepared to handle Ebola and also PVVAX.
Let me start with the malaria question. And thanks, Anne, for being able to pick that in such a remote part of the country. That Kenya, we have made progress as a country in terms of tackling malaria. Under the Kenya malaria strategy, we have reduced the incidence of malaria from 105 per 1,000 population to 72 because of a multi-pronged approach in terms of delivering interventions to be able to control the disease, from larval source management, vector control, use of the malaria vaccine, and distribution of insecticide-treated nets. All these are bearing fruits. But PVVAX is a unique parasite. It's not very common in Africa. It's more common in Latin America, Asia, and the Horn of Africa region. That is Somalia, Eritrea, and Djibouti area. But because of effects of climate change, now parasites which were not commonly found in our space are becoming more common, including the Anopheles stevensii, which was not initially thought to thrive in Africa. And the uniqueness of P-Vivax is that it has a dormant stage in the liver that ensures that even after treatment, there can be a relapse without even a mosquito bite. What we are doing as a country is to be able to move in terms of the challenges that we are facing. Now we are moving to what we call multiple first-line therapy. Historically, as a country, we have always indicated that it's only one molecule for use to be able to treat malaria. That puts a lot of pressure on the parasite, and the parasite also develops its own coping mechanisms. Therefore, beginning this year, we are going to have what we call multiple first-line therapy. So a doctor, provided that the list of the molecules that you have approved, any molecule can be used anywhere. That will be able to reduce the pressure on the parasite, and therefore the risk for resistance will be reduced. So we are aware about P-Vivax. Fortunately, the treatment artemisinin lumefantrine that is used for treatment of falciparum malaria equally works well for P-Vivax. But now with the multiple first-line therapy, Primaquine is part of the cocktail that we'll use. Then towards the end of this year, in the next 1 month, we are also going to distribute more than 10.8 million nets in 18 high-burden counties to be able to bring about vector control. Regarding Ebola, yes, Ebola still remains a public health problem. The situation in DR Congo is still unfolding. And remember, in this outbreak, this is the only outbreak where the DG of WHO was able to declare a public health emergency of international concern without the emergency committee meeting under Article 12 of the International Health Regulations 2005. Uganda has brought the outbreak to a control, but because we are a hub movement between us, DR Congo, and the region, Nairobi serves as a hub. And what have we done? One of the first things we did was to be able to establish an incident management structure to be able to coordinate all the actors to be able to bring the outbreak to a control in case it lands in our doorstep. Number two was to activate the Public Health Emergency Operations Center so that events from all over the country are reported into one central place for action. As at today, we have responded to more than 183 alerts. All we have tested and turned negative. In DR Congo plus Uganda, the total number of cases is northwards of 4,200, and deaths are now approaching 1,900, giving a case fatality rate of 46%. So that tells you how serious this problem is. We believe that our surveillance system that we have put in place through the various points of entry, our capacity for laboratory to be able to test, we have 5 designated laboratories, 2 of them being mobile, one in Busia, the other one in Luahaha, and the one in Kemri, Kisumu, and the CDC lab in Nairobi, and the National Virology lab in Nairobi. We have also built our capacity in our early assessment. WHO gave us a score of 66% assessment when the outbreak began. In the recent assessment that was done towards the end of last month, we had gone up to 88%. So we are on the right trajectory. We want to assure Kenyans that we have put in place necessary systems to be able to not only prevent, but also to detect and respond appropriately if you have a case of Ebola. Thank you.
Thank you, DHA.
Thank you so much. The CS has been helping us to to explain some of these things. My name is Anthony Lenayara. I'm the CEO of the Digital Health Agency. I want to respond to the question by Macharia on the issue of the 2%. The first thing I want to make it clear and factual is SHA is not paying the 2% to any private organization. It pays to the Digital Health Agency. Digital Health Agency is a government institution. It's anchored under the Digital Health Act. Is that 2% legal? Yes. It is within the Digital Health Regulation, Section 11, subsection 2. It's called Health Information Management Service. Why do we pay for this service? It's because digitization is about efficiency. Mercy told us here before in NHIF or even in public or even in the facilities, you will print a lot of documents, okay, by the facility. You fill all of them. The patient must sign all of them. The doctors must sign all of them physically. You will carry them all physically to a physical SHA branch office. SHA branch office will approve it, carry it physically to a regional branch office. Regional branch office will confirm it, carry it physically to SHA headquarters. All those are cost. All those are cost. So what does digitization do? It removes that cost from the facility. It removes that cost from SHA. It creates that efficiency. It makes you not lose that data. So that is what is being paid for. Because you either pay it by printing papers and losing them, or paying it by digitizing your processes. Even your own organization, why do you have ERPs? It is for efficiency. It is for to reduce that so much cost of printing and all that things. So that is what is being paid. Who pays it? Any user of the system, of the whole digital superhighway system. So facility, next time it's another user, any user of the system, and that is how it is in our regulation. So for this 2%, it is paid by the user who is the facility for that efficiency to process their services and to process claims digitally. How did we come up with the cost? We went through a whole government process, the whole process, legal process of public participation. Come tell us how much it is supposed to be cost. We went all over this country. We asked people for question. We went to parliament until it was agreed 2% cap at 5,000. So if your bill is 1 million or maybe 10 million, and you do 2%, maybe that figure is more than 5,000. The law tells us we can't charge anything more than 5,000. We will still charge the 5,000. If your bill is low, is maybe 100 shillings or 1,000 shillings, we'll do 2% of that, a small value. Because we went through the whole publication for the people of Kenya to tell us, cap it at 5,000. So whether your bill is 10 million, 20 million, we will never charge anything more than 5,000. What is that 2% and the rest funding, as I said, efficiency? But we're doing a lot of things in the digital superhighway. You remember our public institutions never used to be paid a lot of claims because they didn't have systems. More than 60% of our public facilities are getting primary health care. Why? We have given them gadgets, 42,000 of them. We have paid for them internet for 10 years. They don't pay. Funded through the whole of that program. You as a doctor today, you don't need to go to the hospital to do that signing and carry papers. From your practice app, Practice 360 app, you can approve. You as a Kenyan today, you are reporting when you have your data in your Afya Yangu app and you didn't go to that facility because there's portability of data. That is what all that is funding. And that is the story of 2%. And when I have time, I will break down the digital superhighway because it's more than that. Thank you.
There was the
Thank you very
104B.
much. Thank you very much.
Madam PS.
The next person to speak will be the COG.
No, they still hasn't answered on the 104 billion shillings. And I want to add to him that we have facilities that charge patients 2% of the bill, saying it's for the digital superhighway. So how come that is yet it is capped at 5% and they're not supposed to pay out of pocket for it? And the 104B. Waziri is insisting you answer that one.
Question that never goes.
Waziri is asking me also. Thank you so much. First, no facility should charge the 2% to the patient. It's actually very clear, even our regulation, it's illegal. Okay? And any that has been reported to us, because I think I got 2, we reach out to those facilities and they stopped that charging. So please, if you have any case, let us know, because we shouldn't charge the Kenyan. Okay? I want that to make it clear. 104 billion. Question. So first, The first thing I want to clarify is SHA system is not worth or costed or contracted or paid or any one of 4 billion. The Dito Superhighway has 43 systems, okay, which is used to provide digitization across public, faith-based, and private facilities. In those 43 systems, SHA systems are only 2, actually, so that I confirm. SHA only paid 25 shillings for any Kenyan who is covered under SHA for 1 year. That is the only thing SHA pays. Are we clear? SHA only paid 25 shillings for you, who's a Kenyan, okay, per year. If you are a Kenyan covered per year, so for example, do 32 million or so amount of number, and you need to remove maybe the dependents and children because they don't pay. So put that figure, multiply by 25, that is what SHA pays for digitization, not 1 or 4 billion. The 1 or 4 billion story is not true. Okay? Now, this 1 or 4, as I said, it has 43 system, is divided into 5 key areas. And now that you have made me you need to give me time because I need a lot of time to explain to it. Divided in 5 key areas. One is the Dito infrastructure. I had already said for all our public hospitals, we are giving them a gadget. That is a tablet or a laptop like that. Pay internet for 10 years. Giving them power banks, wherever there are power banks in it. How many gadgets are we giving? 74,000 of them. Are we clear? So that any of your public facility, including your dispensary, zile ziko kwa kijiji, we will make them be fully digital and have internet connectivity. If you are level 4 to 5 and 6, we pay for your fiber connectivity for the next 10 years as part of that. Second thing, I'm sure many Kenyans ask us about data. Where is our data? Okay? In that 104, we have developed what we call sovereign health cloud. 3 data centers in 3 different locations in the country. So that none of your health data, whether in private or in public, and it's in our law and it's our regulation, should be stored outside the country, must all be stored within the borders of Kenya and in our sovereign cloud in line with our Data Protection Act of 2019. So for those of you who are in IT, cost for me the cost of data centers to protect your data and to store your data. So in terms of data infrastructure, connectivity, data management, and devices distribution to the public institution. Now, we come to what we call the highway, which you can use an expression like this digital like the expressway. So what is that? 6 key components. Component number 1, why you're not able to share data is because how to identify you, or what you call your digital identity, is not unique. That's why in that ecosystem, we build what is called client registry. One single point of truth for every Kenyan. It is what has made possible to you today. You don't need to print cards. You don't need to print anything. For you to access services under SHA, and even for you to go to the hospital, including eliminating those books. By the way, I also saw one for the books, and I was happy that you raised that issue of the books. And it's about change management, because somebody will have a book, but only write your name, because everything else is already in the system. We just need to change their mind that you no longer need the book. And in that client registry, 32 to 33 million of you already have your digital identity of health inside it. That is what we call the client registry. The second, the facility registry. single point of truth for every facility. All those I'm explaining is system with 4 to 5 other subsystems. Facility registry, you remember the cases of NHIF before? People used to have small facility that do more surgery than Kenyatta. Today it's impossible. Why? Because of the superhighway, because of the facility registry. When you register with a regulator, he's able to say, these are the services that you are only allowed to provide. And therefore, if a regulator has not approved you to provide those services, you will not be able to provide under this superhighway. For 2 reasons, of course, to solve fraud and other things, that one is easy, but even for quality, to stop Kenyans from getting services in the wrong facility. That today, all facilities, 16,000 of them are in that registry. Those are other systems within that 104 story and within the digital superhighway. The third one is the healthcare worker. A Kenyan will walk to an hospital, will meet Anthony. I'm an engineer by profession. I'm dressed up in a white jacket. Will I not treat you? I'll be able to treat you. Because you don't know if I'm a doctor or not. Today with the healthcare worker registry, you cannot treat a Kenyan within our ecosystem if you are not a licensed healthcare worker and actively paid up license by your regulator. That's another system. Stops fraud, controls quality. Okay? Yes, the stories of Dr. Mugo and all these type of things. And our law describes, it's not only for public, even private. They all have to come to the highway to support Kenyans not to have this problem. So that is another systems of 3 or 4 systems within that area. The 4th one, terminology service. Why are we not able to do analytics? Why are we not able to do data decision making? Because one malaria, for example, I'm not a doctor, somebody writes another complicated names using ICD-10 codes. Another one writes another complicated name. Another one writes malaria. For all systems to work, all of us must have one terminology. So that's another registry. One language in a simple word. Kenya was to move to ICD-11, I think this you can confirm, around 2012 or so. As of today, most of the facility was still in ICD-10 until we built the superhighway. Everybody is rushing now to move to ICD-11. Better treatment for Kenyans and alignment with WHO standards. That is another whole system. Community health systems. All our CHPs, giving them devices, making them to refer. When they go to to your homes today, they collect that data. How does that data move to your hospital? So that they are then able to help you in referrals. That's another whole ecosystem in the highway. Finally, your virtual file. You used to have books. You used to go to hospitals and have to explain your historical treatment. With your virtual file today, you are able to have your information in Afya Yangu. We're able to store your virtual files in a secured location so that when you give consent, the doctor is able to access it, but only when you provide consent. That is the core of the highway. Move to logistics. Those are the systems, so that people don't say that the one of is for sure. Move to logistics. Track and trace. You saw a publication by PPP where we are telling everybody who manufactures drugs and brings them to Kenya must register it in a track and trace system to remove all the fake drugs, to give safety for Kenyans, and enforce proper standard to it. So the whole of track and track system, the whole of ordering management system for our facilities not to order what they don't require. For data to tell them you don't need to order this amount or you have these ones. I'm sure I saw a lot of reports of saying expired drugs. Why do drugs expire? Because you think you need 20, but actually you only need 5. All that logistics ecosystem, we are digitizing the whole of it, from the facility to the manufacturer. Do I continue with many others? There is telemedicine. There are so many.
Right.
But more importantly, the Kenyan government is not paying for what has not been delivered. That's why you don't see it. You pay for the service you deliver. So when all that is finished and all the system are in place, we ask what has been delivered, what are we able to see, and what services do we receive. That's why you don't see a contract of 1 or 4 in a budget of Ministry of Health than anybody else. It's fee for service.
Thank you.
And when you have time, come to my office. I will explain to many others. Telemedicine. We have not talked to another 38 of them out of the few that I've said. Thank you.
Thank you. Bona Engineer, I see you've become a doctor. ICD-11 is the International Classification of Diseases. So it's the universal language of identifying the diseases, so that I don't say complicated malaria, I just put a code and it speaks to the system.
Thank you. Thank you very much. We had a flow of that, but let's go to KEMSA.
Thank you very much. My name is Dr. Wako Dulacha. I'm the CEO of KEMSA. This is a very good opportunity. Now, mine was a disconnect between, an alleged disconnect between the 94% and what is in the facilities. But let me give you a story about how we reached 94% in less than 2 years. 2 years ago, we looked at the products that are stocked in KEMSA and what KEMSA has been struggling to buy. And we call those stock keeping units, SKUs. So when we looked around and took a stock, we realized KEMSA is chasing 3,800 SKUs. Then I asked my team, do counties and our customers, the facilities, do they really require all the 3,800? How can we consolidate our effort with the little resources we have? And we buy SKUs that talk to the needs of the customers. Because when you look at our core values, every organization has core values. You always talk of customer-centric. So you have to talk to what our customers really require. Then I talked to my team, the relevant teams, the entire KEMSA team. I took them out for a week, go and talk to the systems everywhere and see, do we need the 3,800? Then they came up with what is required. 485 is what has been ordered over the last 5 years, out of 3,800. So we said, do we really continue buying this? Then we said, let's corroborate this information and call in the 47 county pharmacists. They all assembled in Naivasha. We asked them, what are your requirements? What do you really need for us to buy for you? Because we are serving you. And they actually confirmed that that is what they require as essential medicines and medical supplies, the EMMS. Then we said, now, if we're chasing, it's a very different game to chase 3,800, and then that leads you to another fill rate of 38, 40%. It's a different ball game to chase 485, and that is the magic that put us to 90%. I'm not saying we stopped buying the entire 3,800, but we decided to consolidate our effort to what is required by the country, what is required by our public health needs. Yeah? So I must confirm here that our order fill rate is 94, is over 90%. Now, that is KEMSA. KEMSA has two business models. One is what I call, or what we call, not me, supermarket model. So we buy and we sell. It's a big supermarket of health products. So we buy and the facilities buy from us. The other one is the supply chain. You heard of the Prima Queen and other products that the ministry and development partners give us to buy. So there we earn supply chain fees And there we are under instructions to buy. So if the ministry wants Primaquine, they tell us to buy. If it's not out, I know you don't know, so you'll say KEMSA is at fault. So I think it's good to learn what is in our business model to the supply chain and what is in our essential medicines and medical supplies called EMMS. For EMMS is what we talk about, the order fill rate, which is over 90%. So now we have that at our KEMSA. Now what happens is, do the facilities order? And it is not for free. KEMSA has stopped being a push system. It's a pull system. You must order to buy. It must be a request from you. That's why it's called an order fill rate. So the counties, when you hear that maybe they don't have stocks, it is them who have not ordered from us. There's erratic order from them. One, maybe because they do not have the funding to buy from us, or they are shying away because they have a lot of debt with us. So they keep flip-flopping through meds and us. They owe this, they go to meds. So then you start seeing erratic supply at the health facility level. So our assurance as KEMSA is, let us remove this syndrome of hakuna dawa. Is a change management again to our wananchi, that automatically the default position is hakuna dawa in the head. Kenya, please remove hakuna dawa. There's dawa in KEMSA. Thank you very much.
Thank you very much. Indeed, there is dawa. Kuna dawa KEMSA. And Waziri, when I was listening to the CEO, he took his whole team to Naivasha for a workshop to make sure that they understand what it means for safe supplies, make sure there is steady delivery of real safe medicine and also vaccines. Asante sana, another round of applause. We are fixing and reforming the health sector. And that is why we are equally here today to explain to you what it actually means. Because it is not just about giving money to facilities, to damaged hospitals. It is also about fixing the whole system to work for everybody and to be stronger for the future. When we look at the same, what does it mean? It means working together, county government and national government, holding hands together. It means also building a stronger foundation. It means the focus should move to local clinics first. It's not just about building the bigger hospitals, but it is also.
Give to this girl to ask questions.
It is also putting money first in the small local facilities, and that is why the COG is here to explain to us about the service delivery. Mary.
Maswali. No, Maswali.
There was a question for Mary.
Okay.
Yes.
But we want to ask, I want the media to ask all the questions.
Okay, and I can.
It's not us to talk.
And I see requests for media wants to do interviews after this. Please ask all your questions here as directed by Waziri. There'll be no side interviews. So all your questions here, Waziri has directed us so that all his team members here can answer.
Thank you very much, Mercy and the CS. And I think every day is cool. Seated here, I have learned a lot of things that I didn't know. Our wish that the narratives that is being received, because it's verbatim, it is authentic, will influence our reporting moving forward. And the reason as why I always say that media is one of the strongest allies of government and any successful institution is for them to be able to shape the narrative to a common mwananchi. Hiyo tunaambiwa tusomoe hakuna dawa, kuna dawa can only be done by the people that are seated here. There was a question from one Mercy that asked whether county governments have fully embraced health as a devout function, and this was in relation to human resource engagement, hiring, and equipping of the health facilities. I want to specify first that the health digital reforms have actually worked and transformed the health architecture of this country. I say again, I stand testament CS that the digital transformation agenda has actually worked for this country. The fact that we can convene the facilities in charges 30 minutes and they are able to unlock all functions, feedback to both DHA and SHA, for me, digital reforms have actually worked. Now, in relation to fully embracing health, I want to say the 14 devolved functions have made considerable improvements in the service delivery to common mwananchi. Health, however, has been fully embraced by every 47 county in this country. And in relation to hiring, I want to confirm that numbers do not lie, that pre-devolution, we had 90 health workforce in this country, that those included nurses, doctors, clinical officers, and midwives. Right now, 2024 data shows that we are close. We are close to 200,000 employees hired across the entire 47 counties. And for me, devolution is working. I want to give an example of specialized doctors. Wajir pre-devolution had only one specialized doctor. Right now, there are over 79 specialists in Wajir. And I'm just giving an example of one so that we show health has really transformed and the like. When we come to health facilities have grown from pre-devolution from partly 9,000 to over 15,000 health facilities. For me, health is a fully devolved function and it is working. The fact that each and every level 5 and level 4 can afford and give dialysis services to the diabetic persons in this country, for me, health is working. That Kenyatta Hospital no longer hosts myriads of people in this country to come and queue for months for them to be dialyzed. For me, health is working. When we come to equipping, and I want to give this accolade actually to the head of state, that realize that county governments, and of course for us to achieve universal health coverage, health facilities must be fully equipped. And he devised and tasked us with the Ministry of Health to ensure that the National Equipment Service Program is actualized, is working, and that every facility gets equipment that they so deserve for purposes of rendering services to these to wananchi. NESP is a program that has complemented the universal health provision in this country. It is a national health service provision is provision of every equipment that is required for level 3, level 4, level 5, level 6 at no cost of any health facility or any government, any county government. It is actually a fee for service where vendors were identified through a rigorous tendering process, and they were able to confirm that they would actually place every equipment that is required. And for each and every service that each equipment offers, there is a fee attached to it, and that is compounded actually under SHA. So there is no health facility that can actually claim that they do not have equipment to give service delivery to citizens because there's a program that you just get equipment, then for each and every service that is advanced, they recoup back their cost. So in terms of equipping of health facilities, I can confirm through this national equipment service program that is a collaboration between the national government and the county government has actually done wonders, and universal health coverage is actually a real and a true factual statement that health is working in this country. So I believe I've given statistics that cannot be refuted by anyone. Thank you very much, and over to you.
Back to you, Mercy, for another round of questions.
Thank you, Madam PS. There are very many hands on this side, and there's a gentleman here. So allow me to take on this side. Please, if your question has been answered, don't repeat it so that we are incremental unless you're seeking clarification. So let me take the lady here. There's a gentleman there, and then I'll come to you here, and at the back, and then I'll come to this side.
Okay.
Yes, we'll take. I'm clearing this side, then I come to this side. Please remember, ask all your questions here. There will be no side interviews after this town hall.
Okay. Good morning, everyone. My name is Helen Shikanda.
I'm a health and science reporter from the Nation Media Group. First, I have a comment and then questions. My comment is something that most journalists in the room would feel, and it can be frustrating sometimes to get comments from the health ministry and not necessarily from the CS, but even the SAGAs. And I'll give an example of the Pharmacy and Poisons Board, for instance. I asked a question sometime last month about the status of approval on semaglutide. And I asked it because there was a private company that had introduced the generic version, and the PPB last year had mentioned that the Ozempic pens in the country were fake. So I just wanted to seek that clarification, but it takes more than 20 business days to get that response. So if maybe the ministry can help fasten the process in terms of getting feedback from the different sagas in the country, it would help in the work that we do. And then now to my question, which is tied to the state of devolution report that was released last week, which had great strides in terms of maternal and newborn health, but there was one indicator that was a bit off, and that is on skilled delivery. And when we speak to community health promoters, they say that mothers are shunning away from the hospitals because of SHA. They don't have the money to even pay the registration, and now they're opting to go back to the traditional birth attendants. And I'm asking this question because the country launched the Ewene initiative, and we want to reduce the maternal and newborn deaths, yet mothers are now giving birth away from the hospital. So what can you answer in that regard? My other question is also on the clarification on malaria infections data. Dr. Amoth, you've mentioned that we have reduced the cases, but when you look at the data that we got from the economic survey that was released sometime in April or May, the previous year, 2024, it was about 3.8 million, but the latest data shows an increase to 14.3 million. So I want to know, like, what is the exact number, because that is almost quadruple the numbers of new infections compared to the previous year, and what could have led to this increase if that data is correct? My other question is to SHA. What is this, what is the status of pregnant mothers who are foreigners or refugees who do not have IDs and they need to give birth in our hospitals? And for one to register under SHA, they need to have a national identification card. So how can they go about that? What is the status of the fraudulent claims by SHA that the ministry has been talking about? And then another question is on SHA basic services. Some Kenyans are asking why dental services are not covered under SHA, especially the basic ones. So those are the questions that I have. Thank you.
Very good. Helen? Let's just finish with that table. All the hands were up.
Thank you so much. My name is Angela Okech. Angela is the content lead health and science, Nation Media Group. As Bwana Waziri has mentioned, he's one of the officers that has been answering questions. Regardless of how he answers it, he will answer it. However, we must recommend him on that. He will tell you whatever you want to say, but he will answer. But we have a problem with other officers. You will call, they will ask you to send questions, they will not respond. Bwana Waziri, we have a problem getting data in a number of health parastatals. For instance, I'm going to mention this, but I'm sorry. We've been looking for cancer data for the last 3 months. For the last 3 months, we have not been able to get that. We have been looking for data for breastfeeding. We were doing a pull-out on breastfeeding. We were not able to get that. We have been looking for data on menstrual situation and mental. We have not been able to get that data. So when we report what we have, you might say we are not factual, but we are not getting what is factual from you people. So please. My question would go to, I don't know whether Bwana Waziri would answer this or the CEO, COG. It's about the National Equipment Service Program. You've talked about counties getting the latest equipment, even as far as Lamu. However, we are having a problem. I don't know what was the agreement between the contractor, because a number of hospitals are mentioning there is a breakdown in the equipment, but they are unable to fix it because the contractor apparently was not on the site. So I don't know what was the agreement between the contractor and the person who brought the equipment to the county hospitals. A case in point, I know Bwana Waziri will tell me, Angela, give me the example of hospital you are talking about. I'm talking about Jaramogi Oginga Odinga. Please find out about the equipment that is there and which contractor was in place and why the equipment is not working. My second question would go to, we've had a problem, or rather, we've had donor funding cut. We are seeing HIV cases, the new infection increasing. However, we are doing so well when it comes to deaths, whereby we are seeing more deaths decreasing. But what plans do the government have to ensure that we reduce the numbers when it comes to new HIV infections, and are we having allocation in that sector? Secondly, we are talking about, Waziri, you've talked about ensuring that Kenyans are safe. However, we are seeing so many, substandard drugs in the market? So we are seeing many Kenyans, probably they might not be able to know that this drug is substandard, but according to Auditor General and also the report that was released last week, we are having so many fake substandard drugs, including ARVs. So I don't know what the government is doing in regards to this. We are talking about reduction of new infection. If a person takes a HIV drug that is fake, how do we reduce infections? And lastly, to Dr. Mercy, what is the status of release of money to private sector? They are complaining about late payment of SHA to the hospitals. What plans do you have? And so far, which is the leading between the private and the public? Which is one of the areas that you've released the money? Thank you.
Thank you, Angela. And Bwana Waziri, Angela has been polite, but and I think the media here would corroborate. When you call some of the heads or sagas, they'll tell you they need permission from Waziri, written permission, for them to speak to us and give us any feedback. Like, we andika barua, have it delivered, alafu akiniandikia nijibu, then I'll answer. So I think in this digital era, Bwana Waziri, and also to the COG, we need to find a way of digitizing that approval processes, because we understand, officers will need approval. But is there a faster way other than andika barua, deliver SHA, iende kwa waziri, ndio tupate permission for our questions to be answered? Angela, you are very polite on that, but I know that's the experience you have. That's the experience most of us have had.
Thank you. Good morning once again. This is Dr. Zodumbe, Health and Gender Editor at Nation Media Group. I think my colleagues have asked basically the questions that I've wanted to ask, but I would just like to make a comment. Bwana Waziri, I hope some action is being taken, especially in regard to the fake drugs that are in the market. On the question of, Mercy spoke about going to Malindi and paying for a card. So she's a CEO, SHA, so she's aware that she's not supposed to pay. What happens to my mother in the village when she goes to the clinic and she's asked to pay and she pays? Is she aware that that's a criminal offense? So how are we doing public sensitization for Kenyans to know that they're not supposed to be charged? Because they go to hospital and they pay. There are two Marys, so I'm talking to the Mary of the COG. There's currently the ongoing nurses strike, and you say that just a few counties, but even the few counties matter because those are Kenyans who are affected. And I'll give the example of Isiolo, where even the doctors have been on strike for more than 2 months now, more than 60 days. We don't know what the situation is. Kenyans out there rely on us as the media to tell them what is happening. So we'd love to know. We wouldn't want to just brush it off. The way you say that, everything is, we're getting everything sorted out. What is the current situation? If Isiolo, the doctors, imagine a hospital without doctors and without nurses. What is happening in those hospitals? Then the same nurses, at least I edit the stories quite a bit. I'll not be in the field writing the stories, doing them, but Angela and Helen and everybody else, they bring me the stories, so I am quite alert on what's happening out here. So now, regarding the current strike that has been ongoing, some of the stories I've been editing, I see the doctors, I see the nurses asking that health, the devolving of health to the counties is not helping them. And they've been requesting Waziri to take back the health docket. I don't know what you have to say about that. I think the question on fake medicines, Angela asked. And for Mercy, with the love from me and all my colleagues from the media, when we ask these questions, we are just asking from a place of public interest, not out of hostility, because our work is to inform Kenyans, educate them, and we would be very happy to see Shah working, would be very happy to see Waziri succeeding, and we'll tell all those beautiful stories. So anytime we write something that you think is not right, probably many times it's because the Helens and the Angelas and the Mercies have called and there was no response. So what we do in the story is say we reached out, but they never, by the time we're going to press, they never got back to us. But Kenyans need to know what is happening. Thank you very much. And for this forum, I'm happy, and I hope we get to do more of this. Thank you.
I'll take the last one from CEO. He was my former boss. So let me have him answer or give a comment, and then we answer those ones.
Good morning.
And then we take the next round.
I'm Charles Otieno, Managing Editor, Standard Group. We are the bold. So my question to Mercy, Shah, now I want to look at her straight in the eye and say that journalists ask intelligent questions. Number two, and I'm standing upright. I like when I discuss with as people who represent the fourth estate, I like talking to people straight. Yeah. And in the Standard, we do not shy. Yeah. We are very bold. Yeah. Our writers here do not ask silly questions. We ask right questions and intelligent questions, and our job is to shape the narratives for the nation and the country. Now, I hope we withdrew that statement.
On her behalf, she withdrew, she apologized. Even the minister apologized on her behalf. So let's tell you there.
Apology accepted, journalists?
Apology accepted.
Is it accepted?
Yes. Okay.
Okay, now we can
Let's rest it. Now we move on.
Now we can move on. Now we can move on.
CEO Kemsa amesema usiweke headline.
Now we can move on. Our job here is public trust, and what we do with the media is to make sure that we give you information to the public, what you give us, Waziri. And we appreciate the Ministry of Health for what you've been doing. Our question is that sometimes what journalists are saying, that the answers do not come real time. And we need these answers real time, and in the space we require them at that time. That's what Dorcas is talking about. That's what Mercy Kahenda is talking about. That's what Gloria is talking, Angela is talking about. My question is to the blood transfusion in Kenya. What is the data? Why are Kenyans told whenever you are sick to come with a pint? What is the resource for the blood bank in Kenya for Kenyans to be at a safe space? Are we selling Kenyan blood to other countries? Number two, Dr. Luga, you used to be on this side. What has changed? Is it government speak? Are you looking at the...
Maybe you should tell me what has changed.
We will come to you. Kenyans, the doctors, you said there are many unemployed doctors, but if you go to facility, in my village in Ugenya, there are places where we do not have enough doctors. Number 3, what is the Vision 2030 achievement in health and where are we going? Asanteni.
Thank you. Thank you, Charles Otieno. So the questions are varied. We have questions to PPB on the issue of Ozempic, and I think the turnaround time on answering. You want to take that? Or do you have PPB in there?
I think we can have there are questions that belong to the DG, and especially any question on technical issues, cancer, menstrual situation, PPB. Then we have a question on the state of devolution report, where SHA on the delivery of mothers, and Awene, county government, and Dr. Bashir. Then there is also the issue of the status of mothers who are refugees and those who do not come from this country equally. Issue of NESP and donor funding cuts. We also have returning the healthcare docket back to the national government. Maybe Waziri will be able to answer that one. So the last few questions equally. The issue of employment of workers, Vision 2030 achievement, and World Bank. Sorry, Blood Bank.
Who wants to go first? County?
I think let me also be bold. The standard is bold. As head of this ministry, I'm also very bold. And you people know that. So when you tell my CEOs you are bold, then I'm also very bold. But let me start with what this editor from Nation and her team. I think there's nowhere I have said that I must sign when you ask questions. And these good people will agree with me. When they send me questions, I answer. Where's Masika End of Standard? Yeah. She sends me Angela. But our problem is one. We have a feeling that you media want to divide my house. So that my CEO will give, my director will give an answer, and then you look at an answer given by the president, an answer given by the minister, and then you twist it. So we have agreed we are going to have, and from today we are going to have a communication one-stop shop. From today. And PS Oluga and PS, we must have. The way we have one stop for all questions and answers from Parliament. We have layer zones in MOH who will answer petitions, motions, questions. It goes through the PSS, it goes to the DG, the PSS, it comes to me, I sign. So we'll have the same. Because we are accountable to the people of Kenya. And the media is there in existence to hold to account those who hold public offices. I have worked in Parliament for many years, so I know I have worked with the journalists. We will answer questions. And if you are from the Cancer Division here, and if you are from the National Cancer Institute here, you must provide cancer data to these good people by end of tomorrow. The same, I think, was cancer, breastfeeding. And I want to thank first the nation media, because they carry, I think, weekly features on health. So if we give the data, it's fine. But Angela, let me also say, you came to my office, I answered all the questions, but your headline was not what I said. Let me be very honest. Whether maybe the gracious lady sitting next to you maybe has changed. You know, the power moved. The headline and the story inside are different. I'll give it, yeah. And I want to thank the gentleman from Standard. At least Standard don't change. They don't change. But Angela, you came to my office. Let me give a good example. In my office, we sat for more than 2 hours. I answered all questions. In the morning when I woke up, and I usually don't sleep until I see the headline. There are people who sleep. As a good minister, I don't sleep. So that as when I see the headline, I prepare. I start preparing for a response. So I usually respond to your headlines the next day. Very rarely do people in government do that. Am I right? Because what you write. So also, when we give you data like today, please challenge us on the data. And between yesterday and 10th of August, if I'll be in this ministry, working with you people, we will give the people, all of us work for the people of Kenya, am I right? You people must check us, I agree. You must oversight us. But when we give you the right data, either the county government or the national government, like Jaramogi is good, you say Jaramogi, but rarely you tell me, I ask you, which facility? Then you say, no. We don't want to disclose the facility. So how do I answer that question? Because if I've given the facility, I'll ask Mercy, I'll ask COG, and say facility X is doing this. That's it. So I think you are right. We must give you the issue of devolution, strides, and skill delivery. I think Mercy will talk about. I think PS Oluga and COG will speak about the latest equipment program. Then DG will speak about HIV and all the whole space of. But let me speak for Pharmacy and Poison Board. I don't know whether the CEO is here or these people are here. Yeah. Pharmacy and Poison Board was, in fact, the word poison must be removed. I want to remove that word poison. It doesn't augur well. You know? So, Pharmacy and Poison Board was one of the state agencies that required reforms like yesterday. And I'm happy to report today that the board, led by a chair, and the management are people who are competent and who are working for the people of Kenya. Over 2,000 products, we have removed it from the system, which were counterfeit, which were fake. Am I right? 2,000? Total figure of 2,000? 2,300. And the people who were importing went everywhere. They even talked to the media, but we stood firm. We've made sure that Kenya attains ML3, which was a mirage, by October this year. I think the last mission is coming next month. Am I right? Yes, the first week of September. Kenya has a huge manufacturing space. I mean, if you go to the one in Kilifi, Revital, it exports to India, it exports to the US, it exports to Europe. We have also stopped giving parallel importation permits. Am I right? Yes. Because people were bringing substandard drugs. People were bringing drugs that could affect the health of our people. Finally, Anthony did not ask you. You know, and my good brother from Standard, you know, I apologized. Mercy has apologized. You know, he kizungu siye tu. So we have replaced it with the factual. So please, that one, tuko pamoja. Yeah. You know, we are a group that respects. But Anthony did not ask. You know, these characters out there, they are talking of 104 billion on this digital superhighway. And I want to ask here, and the accounting officers are here, where is 104 billion found in any of the budget estimates in the last 4 years? There's nowhere. So the element of government funding does not come in. The whole system has been built under PPP, and I think it's fee for service. I think I've explained. Finally, I think vision, somebody said Vision 2030. Yeah, tomorrow we are going to discuss Vision 2060. So it's a good question. Vision 2030, where is the place for health? Vision 2030 was started by a very good president, President Kibaki. President Kibaki wanted to implement universal health coverage the way he did for free primary education. And those of you who were then in the media, you remember there was Ngilu bill, which when it went to cabinet, because of the cartels in the industry and many other people, that bill could not survive outside cabinet. I was a member of parliament. It died. So universal health coverage was not implemented. I'm just picking the health sector under universal health coverage. Then comes President Uhuru Kenyatta. He wanted to implement universal health coverage. Mercy was part of the team. He started with 4 pilot counties of Isiolo, Nyeri, Kisumu, and Machakos. The same cartels couldn't allow police. And I was his leader of majority. And one morning he said, let's drop this thing. And we move on. But the bold leadership of President Ruto is today one of the signature projects and programs of this government anchored under Vision 2030. Housing was under Vision 2030. A better education model was under Vision 2030. Food security was under Vision 2030. Digitization of all government. Today, I think over 250 services, government services, have been digitized under e-citizens. All of us sitting here, as we sit here and listen to this, we are transacting on many platforms. All that have been achieved under, those were pillars and programs of Vision 2030. Now that they have been achieved under this administration, in fact, we can say that we are the ones who fully implemented Vision 2030. And now that it's coming to its own sunset days, that's why the president is saying, and visions don't belong to government. Visions belong to citizens. They belong to the private sector. They belong to the media. They belong to government. They belong to the farmer. They belong to the herder. They belong to the mama mboga. That's why the president is saying, as Kenyans, let us sit. And now that Vision 2030 sunset days are around, we plan for Vision 2060. So I think universal health coverage, and I think reducing maternal and newborn mortality rates in our country, making sure our mothers don't die, and we come to WHO numbers, making sure that all our hospitals are equipped and we reduce the referral and logistics pathway, making sure that health is universal, making sure that our cancer numbers reduce. And that's what this government is doing, is the attainment of Vision 20. If I go to education, I'm not the Minister for Education, but let me speak for him. I mean, you know, people were asking, how is this thing of the new higher education model going to be implemented? Where is the funding coming from? I remember I was in government, I was in parliament, not government, when President Kibaki was asked, how are you going to implement free primary education? It's expensive, it is. He says, if you think education is expensive, then you try ignorance. That was the answer of President Kibaki then. So if you think, you know, this model of education, I think the bill is before parliament. I think it's gone worse. something university funding, something private, bill. So I think I agree with you. That's why we are here as part of Vision 2030. What has this administration done to achieve universal health coverage? I think the rest, the rest they can answer their questions. I've only answered for.
Yes, Waziri, I was hoping you will tell them also what has changed with me. Because, you have to answer questions on my behalf, Waziri. But I think nothing has changed. I'm very passionate about healthcare. And what has changed is that I no longer have the mandate to call for strikes. Because I have been told to implement, and as you have seen, the doctors are happy, the nurses are happy, everyone is happy. So yeah, and no, it's true that there's been tremendous goodwill in the environment led by our Waziri here and His Excellency the President. It's in the last 1 year that we have paid 7.5 billion of arrears to doctors. 7.5 billion of arrears. We've signed CBAs for clinical officers, for nurses, for all health workers, and I think they know. And if you cover me well, I'm always in the hospital saying that the health worker is the system, that we put in the medicine, we put in the CT scan, we put in the equipment. But the healthcare worker ultimately is the one that makes all of that comes to a service. And this is something that Waziri has been on it. His Excellency the President has been talking about it. I have been talking about it, ensuring that our health workers treat patients right and that they are also treated right. And we have been on this space. But I wanted to answer the questions that we have on NESP, and I also want to give a lot of context. You know, I have the privilege of having worked in hospitals, and I know many of the hospitals that I worked. I worked in Kijabe, I worked in Outspan, I worked in Vihiga, and then I came to Kenyatta National Hospital. Now, many of our public hospitals, if you go there today, you will find the theaters are really run down. You will find many of the patients who require surgery have to be referred. You will find that the surgeons are not properly utilized because they don't have the tools. Now, if you look at the county budgets, you will rarely find opportunity for MCS to put money to buy equipment. To buy a CT scan of 200 million or an MRI of 300 million, or to ensure that the theater is properly equipped at 28 million. And it will always be story, and you, the media, will cover it. You will cover how the MCAs have not put a budget. And then the citizens will be talking to the governors. And then you will be talking about the cancer equipment in Kenyatta. You've written about that more than 5 times. Patients are in the line waiting because the cobalt machine is broken down. And you know what we suffer from? Number one, we suffer from a lack of a budget. Because for you to buy all this equipment for the public hospitals, you must tax the Kenyan. And number two is that even after you buy the equipment, you buy the very good CT scan, maintenance and servicing is a problem. Why? Because we have equipment manufacturers, they come here, they give us a warranty of 1 year, then they service for 1 year, then they go back to Japan and they go back to where the manufacturer is. The skill to ensure that the equipment is properly maintained and serviced does not exist. Because technology for equipment changes very fast. That is why the government decided that instead of struggling to put in a budget, either by the county or by the national government, we are going to have the latest equipment in all our facilities. The patient will get the surgery. This equipment will only be paid for when the service has been offered. That is what we have done with Kenyatta National Hospital, where we have now put a new LINAC machine. That is what we have done with all these facilities, where Mwai Kibaki, where now we are now putting an MRI machine. And I'll just quickly, Waziri, in 1 minute, tell you, we have put 52 digital x-rays, not paid for, not procured. Of course, this was contracted by Council of Governors and the Ministry of Health, ensuring that there is value. Ultrasounds, 68. Mammograms, 6. CT scans, 36. 36 CT scans. You know, general theaters, 67. Dialysis, 25. Laboratories, 157. Specialized urology. You know, prostate cancer is top 5 of cancers. But you go to many of our facilities, we have trained surgeons, but they cannot do prostatectomy. Or they can do, but they have to take 6 hours opening it up because they can't do what we call TURP, okay? So neurosurgery, 4. The specialized maxillofacial, 8. Specialized cardiothoracic and vascular. Because people have to come to Kenyatta just to get a clot removed from the heart. So we have put 4 of them. Specialized plastic, 4. And then radiation, LINAC, we have talked about the one in Kenyatta, and also the MRIs where we have put 2 right now. And we are continuing. And the thing is that the citizen should not be denied a service because we are waiting for somebody to put a budget. Because you are waiting for somebody to put a budget. This is the whole essence of the National Equipment Service Program. And I'll finish it by saying, like, in many public hospitals, we have a 3 to 6 months delay in access to surgeries. We have theater lists that have not been tackled. And this is the problem. So many Kenyans are walking with diseases because the theater is not available. So instead of waiting for 20 years, 10 years for somebody to put, for county government hospital to put a budget, renovate the theater, put in equipment, why can't we help the Kenyan now? And I think if we understand it from that perspective, you will understand the National Equipment Service Program. You will understand it fully. The last thing I want to talk about is blood. I don't know whether Dr. Sirengo is here. Thank you. So I think DG will answer that question. So Mercy, please come and answer your questions.
Thank you. Thank you, PS. Now, last year in the extraordinary summit, His Excellency the President, together with 47 governors, gave direction on maternity services and their access in dispensaries and health centers. And right now, through an allocation of 2 billion Kenya shillings, SHA is able to pay for mothers who require to do deliveries in a dispensary and health center without the mother having to go into the pocket to pay for that. And so the challenges that were there before were sorted, and our mothers are now able to get that care. Now, in terms of registration, if we have any foreigner who is in the country, they need to register using what we call the alien card. If they don't have the alien card, then it means they cannot register for SHA. And the world over, I'm addressing the media and they're there, right? So the world over, when you're setting up UHC systems, you have to look at the citizenry and those who are resident in the country. And for us, it's very, very pivotal, as Engineer explained, that we are able to identify each Kenyan that is interacting with the SHA system. And ways of identifying the Kenyan is through the national ID. Ways of identifying anyone who's resident in Kenya for more than that 1 year is the alien card. For our refugees, they have a status card that we utilize for their registration. If they don't have an ID, unfortunately, they cannot access SHA services, because that's what we need to do to be efficient, to prevent fraud, and to be able to know who we are covering for. Now, teenage moms, mothers who are below 18, well, let's say 19 years of age, can actually access SHA through the issuance of a temporary ID. But because our digital system is so advanced now, by the time that mother turns beyond 18 and gets her birth certificate, We want to be able to have a system where we can actually match that mother to the resources that have been inputted in the system for her. So IDs are necessary. And our call to Kenyans is to get into the different registration centers and get your ID. The PS has been engaging the department, the registrar, so that we can do RRIs in the community, but an ID is something that we cannot relent on as SHA. It's needed for identification. Now, when we come to dental services, it is true. Dental services right now have not yet been activated, and purely it goes back to the envelope. For you to do a root canal on the street where Nairobi Hospital is, I think you know there's a lot of dental clinics there. Depending on the range and the doctor, you need about 800,000 Kenya shillings for a root canal, depending on who you're going to and the complexity of the root canal. What we're doing under SHA is under PHC, basic procedures like basic tooth extractions, those ones are available. But as the dental procedures become more complex, for now, that is a component that we must go out of pocket for, because we've done our actuarials and the need for those dental procedures is not as big as the need for the PHC and other secondary procedures. A country must make decisions. Anytime where you have a limited envelope, you must have opportunity costs. As we continue building the fund, we will continue inputting more services. And we have a panel. I wish we knew, because today Prof. Jalko should have been here. Because then Prof. Jalko is the one who leads the determination of what the benefit package at SHA should look like. And he's currently doing a review process right now. He's completing on the 1st of October. He'll be bringing that report to the Cabinet Secretary. I want you guys to chase that report, because in that report there will be good stories on what is new under SHA and what is out under SHA. And this story will be pivotal because there are some surgeries we will reduce the cost of. So there will be noise in the industry very soon in October. Surgeons will be complaining, but then there'll be other people who will be saying the reimbursements are now better for certain procedures. So Kenya has put in a mechanism for determining what is in, what is out, and at how much. So in time, Prof. Jalko will go in and look at dental, even optical. We've heard people making requests for hearing aids. For you to do a cochlear transplant, if you need a cochlear transplant, it's 4.2 million. In the cheapest hospital in Kenya, 4.2 million. SHA right now cannot afford that. But in time, as we continue introducing more resources into the fund and then doing the determinations through Prof. Jalko using HTA and other mechanisms, we will keep expanding the benefit package. There was the issue on where are we with the fraudulent claims. To date, and I think my CFO has left to go to a treasury meeting, but he was telling me we've done a recovery of close to 300 million to date in our finance systems, and we are still recovering more. The fraudulent cases in SHA are in different stages, and it's important we understand this. There's cases that are in the stage of investigation under DCI, and those ones are ongoing. There's cases that are under internal investigation at SHA, which then have two branches of action. There are cases that go into administrative action. There are cases that are forwarded to DCI. There are cases under ODPP, about 28 million, that are being engaged through ADR at the ODPP's office. What SHA has been able to recover from providers who've come back and said, you know what, you are right. Here's a check of 4 million. Here's a check of 3 million. Here's a check of 2 million. All those monies we've gotten back from providers are coming to 200 million that we've recovered from providers who've come and written checks to us saying, we agree, take back your money. So it's a continuous process as we continue reviewing issues of fraud within the fund. And again, I'm seeing Angela, I like reading faces. So Angela has a question. Just to define again, Angela, cases under DCI are still ongoing, not yet determined. Cases under courts, and I don't know if Terry is here, we have about 15 cases in the courts that are undergoing the normal court judiciary processes that will be determined by the judges. Then we have cases under ODPP that are going under ADR. Then we have cases where providers have come in. They've said, you know what? Yes, take this back. That's about 200 plus million that we are continuously recovering from fraud. I'll come to you. We'll discuss, Angie, your next question. Now, the last bit that I wanted to talk to is on maternity services and late payments. We've talked about county governments and SHA owing county governments about 4 billion. Golda, I don't know what the number is, private sector. 22,
About 5.
And 5 for FBO. And that, remember, needs to be aged. Why do we owe private sector more? Because private sector actually claims more. If you look at the shift payments that we've done and you break them down through, I can see Golda on her computer, check. If you break them down through county, through FBO, through private, the private sector actually does more surgeries. The private sector actually does more bed days for high-cost cases. So even when we are paying out under shift, almost 57% of that goes to the private sector. So it makes sense that they would be owed more because they are lodging more. However, in PHC, it changes. In PHC, county governments take about 67-68%, and then we have private sector and FBOs. So the two funds depend on the activity of what you're lodging as a claim. So I think with that, Waziri, Shara is done with this part. Yeah. Emma?
Okay. Thank you very much. Yeah, thank you very much, Angela. The fact that you've actually crunched the numbers for the State of Devolution Address, we do not take it for granted. That you actually crack down the numbers. And these are not just the numbers, it's for purposes of information to the public. Yes, the skilled birth declined in the year, and Mercy has been able to explain the reason behind it. There was a policy pronouncement that our level 2 facilities were classified as not offering maternity services in the advent of SHA reforms and the like. But thereafter, we had an engagement with the head of state and the Ministry of Health, where we were able to present the numbers that skilled birth is declining as a result of this, because mothers had to walk kilometers and kilometers to go access this very extremely vital service to them. And this saw a policy change that was pronounced late last year, and I tend to believe this year numbers will improve. So the sole reason is for purposes of that, but that policy direction has already been corrected by the minister himself, communicated to all facilities, and I can confirm that level 2 across the entire country are offering maternal services across. So every mother should be able to walk into any level 2 and get free maternal services thereof. So yes, that is it. In terms of GOTRH, in terms of the NEST program, I want to say that the NEST program is a full package. It encompasses maintenance, reagents and consumables and placement. So if a machine has broken down, it is actually a matter of the facility in charge to just place a call, and the vendors will come, maintain them, service them, and provide reagents for purposes of continuity. I have confirmed, and CS, you may need to note that we have a forum that includes Mercy Mwangangi and Lenayara, and all the service providers and all the facility in charges, for purposes of ensuring that we unlock every SHA challenges, we unlock every digital challenge and every NESP challenge. All of us are in it, and I can confirm for the last 1 month that we've activated that forum. These people do not sleep. They offer, frequent responses and the like. I've actually engaged the in-charge facility GOTRH, and he's confirmed that he's already engaged, and the in charge of NESP, who some of them are seated here, they are actually picking it to ensure that the facilities are, done. In terms of the health hiring and the like, my friend has talked about Ugenya. Let me confirm that hiring of health workers is not an instantaneous thing. It's a progressive thing. And equally in every civil service, you do not employ optimally. You continue employing on need, and based on the numbers that I've given in terms of the growth of facilities in this country, there has to be provision of resources for purposes of hiring more health care workers, which is a priority for purposes of service provision. So it's a continuous process, and hiring is on need basis. So some of these things will not actually happen instantaneously. A senior editor, my friend, it is actually progressive. So I think I want to rest at that. Thank you.
Thank you also to buttress on the Ewene, because Ewene came as a result of the stall in progress that as a global community towards reducing preventable maternal newborn deaths and therefore we came with 90 by 90 targets and 80 by 80, meaning 90% of pregnant mothers ought to have a minimum of 4 antenatal visits, 90% skilled birth attendants, 80% postnatal care for the mother and the newborn within the first 48 hours, and 80% of the facilities being able to provide emergency newborn obstetric care services. As a country, we have made progress, but challenge still remains, and because we are having this conversation, it's only about 7 out of 10 mothers who achieve the required 4 antenatal visits. So we appeal to you to be able to help us advocate for mothers to be able to go for the 4 antenatal visits so that we can be able to prevent these unnecessary deaths. In terms of skilled birth attendants, we are on track. I think it's at 89%. And if we continue maintaining the investments that we have made, we are likely to surpass that figure by 2030. Postnatal visit within the first 48 hours, we are at 78%, again on track as per the EWENE targets. And if we continue again, that target will be achieved and probably will surpass the target. We are making huge investments in terms of emergency newborn obstetric and emergency care through investment in equipment, distribution to the facilities, health workforce capacity building, and mentoring. Coming to the question of malaria. Blood. You want me to go for blood first? Okay. Blood, as a country in the year 2025, we collected 415,000 units. The WHO mantra is that a country should be able to collect 1% of its total population as its blood requirements needs. So our target that year was 550. We achieved 415,000 units. I can categorically state that we don't sell blood to anybody outside the country, and if you have evidence to that, please table the evidence so that we can be able to do the necessary investigations. We have also built that infrastructure for blood. We have the 7 regional blood transfusion centers, Garissa coming as the latest, about just 2 months ago, launched by the Cabinet Secretary to be able to support Garissa, Wajir, Mandera, Marsabit, and Tana River counties. And there's no single county in this country that does not have a satellite blood transfusion center. Further, as hemorrhage as one of the leading causes of maternal mortality, during the launch of EWENE, His Excellency committed a further 1 billion Kenya shillings to be able to strengthen our blood ecosystem. Availing these resources, we will be able to ensure that we achieve our target of probably 560,000-580,000 units. But as media, we need to be able to demystify one fact, that donating blood causes you no harm. We should be able to be altruistic to be able to donate blood, because there's no replacement for blood. As doctors, we have not discovered something that can be able to replace blood. So we need to be able to advocate for more Kenyans to come out and donate. We know those who have donated serially, and we recognize them during the World Blood Donor Day celebrations. So we need to be able to work with you to support us so that we can advocate for more blood. I just needed to provide clarity.
Short one, Bonadiji. The question usually that comes from media is, donating blood is free, but when I go to the hospital to receive that blood, there's a cost to it. Why is that the case?
Because donation is just but one arm of the process, because that blood that you donate needs to be screened for what we call TTIs, transfusion transmissible infections like HIV, malaria, and syphilis. But that is a cost that the government bears. So you should not be charged for that transfusion, because that is part of this 1 billion that we are investing. And the annual allocations in terms of budgetary estimates to be able to provide blood at all facilities. The question about malaria, the figure is 4.1 million cases, and that figure came down from 5.5 million in 2023-2024 because of mass net distribution. And also we undertook a critical step in terms of vector control called IRS, indoor residual spraying, which we did in Homa Bay, we have done in Sia and Busia. And surprisingly, malaria cases dramatically reduced in Busia. We had to go and pick the malaria medicines to distribute elsewhere. So very, very good progress made in that prong. In terms of HIV, yes, adolescents and young people now account for nearly, adolescents aged 14 to 25 years account for 4 out of 10 new HIV infections. If you stretch that age to 34, they account for nearly 6 out of 10 new HIV infections. As a country, we have made progress in terms of the global 95 targets. We are 93 in terms of Kenyans knowing their HIV status against 95. We are at 91 against 95 for those who know their status, then going for treatment. And we are lagging behind slightly in viral suppression. Those who go for treatment, 95% of them ought to be able to achieve viral suppression. We are at 87%. These figures came down because we reworked our persons living with HIV population, which went from 1.3 to 1.4. And therefore, for adolescents, we are making targeted messaging. We are making it possible for you to be able to self-test in the privacy of your house. We are also introducing new molecules for control or prevention from the oral PrEP. Now we have the long-acting PrEP, which was introduced about 6 or 7 months ago, where you just require 1 injection every 6 months, and the uptake has really been encouraging. But we still have a problem with adolescents and young people. We have a problem with men, 1, knowing their HIV status, number 2, seeking treatment, number 3, adhering to the treatment as prescribed by the doctors. We also have a problem with our children, because children are usually voiceless. Let's all speak for our children, so that those who are diagnosed then are quickly put on treatment. Their parents or guardians ensure adherence, so that we can also be able to achieve the 95 targets for everybody. Well, there is nothing for us without us. We will continue in terms of our policies, technical guidelines, to be able to engage the adolescents in the development of these processes, so that we don't leave anybody behind. Thank you.
Thank you very much. Ladies and gentlemen, let's appreciate him. There are a bunch of Nairobi poets who once said, tuendelee ama tusiendelee. So are you ready for one more round of questions? Are you ready to ask one more round of questions?
We want to take,
I believe you are.
3 burning questions. There was that
Awesome.
gentleman here.
All right.
There's a gentleman right behind here, and there was a burning one on this other side. So we'll only take those 3 questions. I believe that, during the answers by, the leadership, some of these things have been answered up and apale, unless you really need specific clarifications. So we'll just take those 3 and end the questions there. Go ahead.
Mine is not a question. Tusalamiane kwa hewa. Turn to your neighbor, tell them, at least journalists are intelligent. Turn to your next neighbor, tell them, at least journalists are intelligent. At least journalists are intelligent. Please.
No, we had closed that chapter. I don't want us to open it.
Listen.
I don't want us to open it, so just make the comment very brief because of time.
Mercy, my name is Wanyama Wachebusiri, a former BBC journalist and a member of the Kenya Editors Guild. As a senior member of the Kenya Editors Guild, I have to talk about it, Mercy, sorry. Because, yes, and I'm not going to talk about it in bad light. Listening to all those speeches when I was seated there as a seasoned journalist and also as a consultant, there is what we call lack of media literacy among these officials. They don't understand how the media operates. Journalists, am I speaking some point? If only you knew, and the only other person who knows how the media operates here is Dr. Amoth, perhaps politician and Dr. Aloga, and of course. And therefore, what I want to insist is the media is not a conveyor belt. So that today, even if a headline was to come out of this place, pertaining to the small alteration we would have, you will not be surprised. So media literacy is very much key. What am I saying? As a ministry, perhaps you may consider that some people, or rather some senior officials here, must undergo some public media relations. It's very much important, I'm telling you. It's very much important and very crucial, because this one will eliminate some of this myth that we have about the media. Like, for example, when the minister was saying, my sister there went to the office, and then the following day, the headline was too bad. If you understood how the media works, you'll not be surprised. Because the media, just like medicine, engineering, we have our own way of doing things, okay? And we don't operate in a vacuum. We operate within the ethical considerations. And lastly, as the Kenyans Guild, we were a bit concerned, for example, at the ministry level in terms of communication. When at some point, Mr. Minister, we know, we love you, but at some point, there has been some consistency in terms of confrontational and at times that borders on bullish tone on journalists. It doesn't augur well. And you know what? That overshadows all the good things that the ministry has done. So let's take on that. Thank you.
Thank you very much, Wafula. Bonaziri, I'll give you time to just comment on that later. I want to take one last one and another last one here.
Okay, thank you for giving me this opportunity. I am Samuel Do Ouma, health and science journalist, and also an editor with Health Business Magazine. I have two questions. The first question is for the DG, and it's on MPDSR, since Eweni has been discussed here at length. So the question is, we have a system of investigating maternal and perinatal deaths known as MPDRS. But why do we still have these preventive deaths while every day, every morning, the officials are being told on what happened and what causes those deaths, yet the gap still is there? Specifically, on the MPDRS, the issue that comes out each and every time is an issue of referrals and emergency transportation, that is maybe the ambulance services. Recently, you launched the ambulance, the 922. How is this going to fix the problem that you people get every day in those reports at MPDRS? That's my first question. The second question is on implementation gap that I just bumped into when I was doing some story on a neurosurgery procedure. I will read it because I'm not a medic. I'm not very intelligent on medic things. So it's called endoscopic third ventriculostomy with choroid plexus culturization, that is ETV-CPC. It is covered under the benefit package number 344. Just to show that I did some research. So on this, the benefit package is capped at 208 Kenya shillings, and it's a procedure to fix hydrocephalus. So one, there are very few facilities in Kenya, like 3 that I know of, that offer this service. One at Kijabe, I think one at the coast, and I think one is in Nairobi. That fact alone shows that patients have to travel in all corners of this country to come and access that care. And that brings about the hidden cost on maybe the transport and accommodation if this patient and the caregiver has to sleep. That is one gap on the hidden cost. The second gap in that coverage is that imaging and scans are only capped at, I think, 4 per year. Yet, this is a lifelong condition that requires frequent imaging, frequent scans, and frequent examinations.
Okay.
The last part is that this condition is not included in the chronic package benefit list.
Okay.
So, and it is a chronic condition. So there is a gap.
All right.
And just to get a comment on from Dr. Mercy, because when I reached out to Kijabe Hospital, the matter was even complicated because the neurosurgeons at Kijabe told me that there is a directive from SHA telling them that they don't offer this ETV CPC, but they do shunt. But shunt sometimes, according to studies published in the medical journals, is not very effective as this ETV CPC. So,
thank you.
The question is, when? Oh, okay. He has also alluded that maybe in October there will be a review. But can we be communicating to maybe Kenyans so that we know that maybe there is a shift? For example, when you go to a service provider at the Kijabe, they tell you that they will not provide
end
this.
there because I think we have gotten the gist of the question, and Dr. Lestan will be answering
Thank
it.
you,
And
thank you,
Mercy,
thank you,
Thank you
Mercy.
very much for that elaborate. And
One final question, please.
I'm Elizabeth Atieno from TV47. My question is on family planning. So what is the supply versus demand gap when it comes to family planning in the country? How much does the government need to bridge this gap so that we can have adequate supply of the family planning commodities? And lastly, the ministry was expected to disburse 250 million to KEMSA by June, just so we can have a streamlined supply of family planning commodities, but there was a delay. What has caused this delay? Thank you.
Thank you. Thank you for being very brief. The last one.
Thank you.
Very last one.
Thank you. I'm also going to be very brief. It's working. Okay. So I'm also going to be very brief. I've actually rounded my questions to one.
Can't hear you.
Can you hear me now? Thank you. Yeah, thank you. So my name is Chris Finn Magak. I am the digital editorial lead for MediaMax. I was saying I'm going to now round off all my questions to one, and thanks God because it's coming at the very last point. Listening to everybody, every submissions that we've had here, led by Waziri's presentation, you realize that actually SHA is to some extent working, or a lot of things in the health sector is working, but if you go to the ground, you see a debate where people ask questions, is it really working or not? So my question is, as a government or as a ministry, what is the challenge that you guys have in communicating all these progresses and bottlenecks to Kenyans, even beyond the media? Thank you. Thank you very much. So I may not answer for the government, but I can say this, that my name is Dr. Misheni. In 2024, I was a medical intern. I had just finished med school, and I was really looking forward to beginning my journey as a doctor. And unfortunately, we were held back for a very long time. We were held back. Remember those doctors who slept outside MOH? I was one of them. If you remember, I was there. Yes, we were there. If you remember correctly, even more, Dr. Mike Misheni and two others took SRC to court to complain and to really take them to court over what was happening. That was in 2024. That didn't happen in 2025. That did not happen in 2026. So they're doing well in some aspects, and I really love your question, and I hand it over to them to continue.
Thank you. So I think we start with thanks, Dr. Misheni, for confirming that interns are no longer sleeping at the gates of MOH.
Yeah.
So we'll take with Dr. Lesan or Oluga. Okay, you'll guide on the ETV.
Yes, please, Dr. Lesan, proceed.
Yes, good afternoon. Yes, my name is
Dr. Lesan, you come here.
Yes, good afternoon again. Yes, my name is Dr. Lesan Joel, Senior Director, Clinical Officer, Clinical Services, Kenyatta National Hospital. I'm a surgeon by training. So he's asking about a procedure that is struggled to mention it. But basically, it is for treating those people who have got problems with flow of the CSF in the brain from one chamber to the next. So initially, in the old method, a shunt would be put from the head to the abdomen. And that would need to be revised, particularly if you're a child, as you grow up, because the length of the body increases, so you have to keep revising it. But instead of that, what one can do actually is just to put a shunt that will drain from the front compartments, the rear compartments, just minimally, just making a small incision, probably passing through the nose, and then just putting a shunt in there. That, of course, is an advancement. It's minimally invasive. The duration of stay in the hospital is very short. The pain or the struggles that the patient has to go through is also minimized, which is an advancement on its own. It, of course, requires more advanced technology. That means the hardware that you put in is much more expensive, and probably that is why you found it at Kijabe or any other hospital. But I'm happy to say that Kenyatta National Hospital has got it. We use it for training with the University of Nairobi as well. So we have it at Kenyatta National Hospital. It's a procedure that we carry out now at Kenyatta National Hospital. When it comes to payment, what Mercy talked about is the ICD-11 coding. So once you identify the disease and you have the terminology right, then you can match it now with the SHA and actually put your claims through. So there should be no trouble about it, so long as it's a condition that is known. Where it has not been included or where you find challenges getting it on the SHA reimbursement services, then that is now where the Professor Jaogo's team comes in and is under revision. So you appeal into that section. But in the meantime, you actually get paid for that. So we don't have a trouble with it. It's a matter of terminology and putting it right. So you get a reference number and you get paid.
Thank you. So I think for the members of the public and the media is that Kenyatta National Hospital have all of these procedures. Often we think that these procedures are only in specific facilities. And again, it relates to the last question because we have not come out to unpackage what procedures can we offer at Kenyatta, at KUTRH. That's why we are here. Guys, I want us to calm down. We are here because we need each other. Are we okay? We are here because we need each other. And we are here so that the public can know the things that are important, which we can't tell them. You are the ones who can tell them. So if we came here and we spoke and you didn't tell them, then I want us to agree that even for you, you shall have somewhat not met that responsibility as a Kenyan, that you had some very useful information that could help a Kenyan somewhere. You knew it as a journalist, as an editor, that you know very well there's a mother who is suffering, that there is a patient who can get this procedure from KNH. We told it to you, but you chose not to tell them. I think there may also have to be some moral, just a moral obligation. Anyway, DJ.
Thanks, Samuel Doe, Dr. Samuel Doe, for that question. This is one of our accountability frameworks, MPDSR. Unfortunately, we have not made progress, especially in the perinatal, the P, and the response. So we are glad that now we are on the right trajectory. It's one of the accountability frameworks The counties, I want to congratulate the counties because they have institutionalized this framework. And now we have what we call inter-county MPDSR. We have a weekly webinar where counties are able to discuss cases, showcase best practices, and that is the best way to go. Then in terms of family planning, yes, we have one of the oldest programs in the region. Our family planning program started in the 60s. Our demand, unmet demand, is 14%, meaning we cover 86% of the population needs. And in terms of availability of the products, KEMSA CEO is here. There's an ongoing procurement of 500 million shillings to be able to buttress our commodity security. Finally, HE, His Excellency the President, committed during the launch of Ewene to allocate 2.5 billion additional resources for family planning to ensure that we meet our annual need of approximately Kenya shillings 3 billion. Thank you.
Thank you very much, DG, Dr. Amoth, and thank you, everyone. Part of the reason we were here to have all of this conversation is a precursor to the Kenya Health Summit, as you can see on the banners we have here and some of the roll-up banners. And I want to show you a brief video and invite all of you as my colleagues in the Fourth Estate to be part of the Health Summit next week, to do a media coverage. As you've seen, there's an open call from the ministry, from COG, for you to reach out. Also do the mystery shopping so that you can give the feedback, because at the end of the day, it's you and I that benefit. So I just wanted to show you something brief. So in short, those are the key discussion points that will be happening on the summit, the key reforms that have happened in the health sector. You can pick any of those topics. My favorite is usually the healthcare at your doorstep, because when you interact with the community health providers, they give you real feedback of what's happening on the ground, whether these reforms are working or not. And most of the times, they'll tell you of stories of people whose lives have been changed just because community health providers have been able to reach out to the community. Bwana Waziri, thank you so much this is the first ever media town hall that we've had. I've seen people, they've sat throughout the 3.5 hours. Yourself, you've sat throughout the 3.5 hours. You know, with Oluga, we've come a long way back in the trenches. And the ministers then would just come, give a speech, go, or do 5 minutes, 10 minutes, and go. So we thank you very much that you've been very open. I'm happy about the Communications and Media Liaison Unit. So I'll follow you up so that you share that information with us, so that the Fourth Estate, the media here, know who and where to reach out for when they are looking for any information on the media. Misheni, just say your name.
My name is Dr. Misheni. Very happy to have been your host for this morning. Thank you for your attention and also for your lovely, lovely questions.
And mine is Dr. Mercy Correa. I've been your host. Thank you for honoring our invite. Allow me to welcome Dr. Oluga to come and we close this session.
Thank you so much. I just want that we give all ourselves a round of applause for wonderful discussions. I think, as you have noted, health is very broad. The issues are very personal. They can also be very emotional. We, as a government, are intent not just on answering your questions, but answering the call of every Kenyan for a responsive, sustainable healthcare system. We believe that you are asking these questions on behalf of real people, and we know that we are implementing this program on behalf of His Excellency the President, who has called for a summit. And to wrap it up, I would therefore like that we have sat for so long, let's just be upstanding as we invite Waziri to close for us. Thank you so much, and see you next week, Tuesday, Wednesday, 18th and 19th, the health discussion continues.
Thank you, PS. Please, let's be seated. I think it was a very good morning. It's one of the best days I can say, because we have explained ourselves. And I want to urge my team that I have a very long history with the Kenyan media. And my brother, the consultant, the way you people ask questions is different. So also allow me to answer the questions the way I want. That's found in the Bill of Rights. So you can't tell me this is your scheme of work. And I'm sure you guys also have. All that we need to do is to make sure we work together. If I am asked today by a Kenyan in the street or anybody, Minister, tell me 1, 2, 3 things why you feel the administration of President William Ruto should be given a second chance. I'll start with health. And by the way, numbers and data don't lie. We will provide data, we will provide, whether it is in health, whether it is in agriculture, whether it is in education, whether it is in food security, whether it is in infrastructure. I was telling somebody this morning that even removing the railway from where it ended somewhere in Naivasha to Malaba was done by this government. Building the Rironi Mau Summit, building the biggest ever road in the region from Isiolo to Mandera, 750 kilometers at a cost of 100 billion. Making sure 32.2 million Kenyans as of today are registered with SHA. They don't need to carry an NHIF sort of a card. They don't need to carry an MRI documents, all their data. They just walk to a facility. The doctor doesn't need to be there physically. In 1.5 years, SHA, you know, I was wondering, there's a world of difference between SHA and SHIF. SHA is the institution. SHIF is a premium insurance, social health insurance fund. It's one of the funds. You know, I could see somebody yesterday was struggling between SHA, SHIF, SHA, SHIF. SHA is the name of the institution where Dr. Masi is the CEO. SHIF is like the primary, is one of the funds. In fact, we have got 4 funds. We have got primary health care fund, we have SHIF, we have ECCF, and we have the PMSF. Today, 178 billion has been paid to our health facilities. If it was for NHIF, good people, NHIF used to pay quarterly about between 5.5, 5.6 billion. SHA pays annually, monthly, by the 14th. I think Mercy has how many days? 3 days to go. 12 billion. So if you divide the 178 billion of 1.5 year of SHA existence to the former NHIF, is like 6 years, former NHIF will pay what SHA has paid in 1.5 years. Today, a mother can walk to a facility, level 2, level 3, level 4, deliver, go home. There's a whole program for teen mothers under SHA, paid for by the government, the equipment program. So I think I agree with you and the media, and let me assure you, at least for the Ministry of Health, let me assure you, I think it's good I have met Chikanda today. Physically, I have seen her, you know? And I don't know why, you know, in nation media, the tough ladies are there in that corner. So today I've even known your boss. Well, The person you take so I can assure you, I am going to put a strong communication team at MOH, a one-stop. I'll do it. You know, all these agencies have got communication people who I've never seen. PSS, I want to have a meeting with all the communication teams at the Sagas. We form one because as a government, as a ministry, there is a moral, constitutional obligation that we must answer all questions asked by the media, by other stakeholders, by the citizens. And we must answer and give the right answer. What the media will do with that answer is not our business. But we must give. You know, now, I am very much shocked that you are looking for a data on cancer for 3 months. No, that is not right. I think that is not right. And PSS, you must go to media houses. CEOs, you must go to media houses, TV stations, and answer hard questions. And you must share the headlines with me. Yeah. You must share the headlines, and you good people, when you put me, make sure at the bottom you put their photos. You know? Please, sometimes you only put the president, and then you put me. These people, they are also part of the decision making. You put Dr. Amoth, and then you look for the family head, the division head, you look for DHA. This 2% issue was a petition in court. I was the one who was put the headline. The man who runs it is here. You should have, you cannot only put me on top there, but below, put some people so that even Kenyans can know it's not only the minister. But I want to assure you this is a very good meeting. Please help us, be part of us at the Health Summit. Be part of us, our development partners, our colleagues from the private sector, faith-based government, our county governments, the fourth estate. We value you. Personally, I value you. I like answering, and people sitting here, they know. And if you go to parliament and you ask the media that covers parliament, if they had a friend, is me at that time. So please, sometimes I will, if you ask me a question, I will tell you the matter is in court. Yeah. This is a no-go zone. So that is an answer. Am I right? Yeah, because at least you answer. Yeah, you know, I was told this. So you also have to look for where to hide. You know, I'll say the matter is active in court. But I must use the word active. When I was in parliament, when I got to parliament, I said the matter is sub judice. I quoted the standing orders. I said, Mr. Speaker, I can't answer this question because this question is active and there's no way I can discuss it. And the Speaker, because I have quoted the standing order, the Speaker will rule in my favor. It's not that it is the law. So I also do the same with the media. But I really want to thank everybody here, my brother from the Standard, our team from Royal Media, our team from The Nation, and all the other media, TV47, Media Marks, everybody here. That gentleman in the white shirt that you are referring to, a doctor, the last time he asked me a question, he was asking on behalf of Reuters. So I was expecting him to say, I'm from Reuters. But I think he asked me a question, I am so from Reuters. So today he said something else. So, it was Bloomberg. Yes, I remember. Yes. I confused you with the other gentleman. You are from Bloomberg. But I am ready, and we will help you, because it also helps us that you have one place you can ask questions. So we will make sure we will do one-stop shop, that if it is family division, the DG and the director will have all the answers. But I also want to thank my ministry team, the sagas and everything. When the media ask me questions, I usually send to them. The only problem is some they answer back within 20 minutes, some they answer me the next day. No, media has a timeline. In fact, after 4 o'clock, the media has no time. In fact, yesterday at the broadcast, I was telling them, no, 5 o'clock. You guys will be covered the next day. If you want to be covered today, The media, both TV and the print. In fact, the print can give you some leeway, but I'm sure the TV has a... So when they ask questions, we must also answer very fast. Of course, factually, but we must answer. Thank you very much. Meet you on the 18th and the 19th. Let us all together showcase what we have done, the reforms we have brought, what we have delivered, and what is in the pipeline for delivery. Thank you very much, and may God bless you. And thank you, Dr. Mercy and team. Not Mercy of Shah.
Thank you very much. With that, Waziri, do you allow us to leave now? You know, you said thank you. You've not told us whether we are leaving or we are staying. Okay. I think we can do the national anthem, final one. And as we get the anthem ready, please, members of the Fourth Estate, we will send you the link to register for the summit for your accreditation. You need an active Media Council card and your national IDs for your registration and accreditation. So national anthem, and then after that, you're all free to leave. Asanteni sana. Thank you. Thank you.